Welcome, colleagues, to the second day of our first annual OncoAlert Colloquium. Along with our partners at MASC, SIOG, eCancer, and VJ Oncology, we bring you the first of its kind year in review for some of the biggest news in oncology divided by tumor group. OncoAlert is an oncology network of medical, surgical, radiation oncologists, oncology nurses, cancer researchers, and most importantly, patient advocates who fight cancer through the spread of reliable scientific information regarding cancer and cancer treatments, fortifying the voice of our patients, and the promotion and creation of oncology education that is accessible for all. Our goal with this colloquium is to provide our colleagues with reliable year in review by some of our OncoAlert faculty who are leaders in their field. This colloquium, like every OncoAlert initiative, is without sponsorship. Everything you will see today and during the week is possible because of the dedication of our OncoAlert faculty and friends who believe that colleagues can make a difference in the education globally, regardless of financial possibilities. As you have noticed, there is no signing up, there is no registration, and these videos will always be in our YouTube channel where they can be shared, and we encourage you to do so. Today's presentations are the best of 2020 in lung cancer and the SIOG sessions. Dr. Solange Peters presenting on non-small cell lung cancer, Dr. Stephen Liu, small cell lung cancer, Dr. Henning Willers, lung cancer radiotherapy, Dr. Lecia Sequist, lung cancer screening, Ms. Jill Feldman, what the year in research means to the patient advocate. We end the session with the SIOG sessions by Dr. Ravindran Kanesvaran, talking about public policy in COVID-19 in geriatric oncology, Dr. Nicolo Battisti, giving an update on geriatric oncology in 2020. We hope that you enjoy the colloquium, and we invite you to join us for day 3, where we will be going through the best of breast cancer in 2020 and great topics like immunotherapy, liquid biopsies, and targeted therapies. So without further delay, Dr. Peters.
Dear colleagues, it's my great pleasure to share with you today some of the non-small cell lung cancer highlights from 2020. Of course, it is a subjective choice, and I will probably also make some personal subjective comments and remarks about this data. This is the agenda of today. We will discuss the most important topic of this year, I guess, frontline immunotherapy for all advanced non-small cell lung cancer patients. We'll discuss early disease with chemoradiation and IO for locally advanced non-small cell lung cancer. We will cover the, I would say, new fields of immunotherapy for early surgical resectable non-small cell lung cancer. We will go through some targeted therapy data for advanced non-small cell lung cancer. And we will not open the debate, but briefly discuss adjuvant targeted therapy in the context of oncogene addiction. But first of all, this is my disclosure slide. So let's start with the topic of frontline immunotherapy for all advanced non-small cell lung cancer patients. This is not only a title, but also a paradigm that has to be nowadays followed. So first of all, let's keep in mind all these drugs were mainly targeting 2 synapses in non-small cell lung cancer, the priming phase synapse of the CTLA-4 and the effector phase of the immune response synapse of the PD-1, PD-L1 interaction, PD-1 signaling, with various drugs, ipilimumab and tremelimumab as anti-CTLA-4, and the growing number of anti-PD-1 and anti-PD-L1. You can see the names on the left-hand side, with probably it's a good thing with the I would say continuous development and current development of many anti-PD-1 or anti-PD-L1, which will probably result in many ENCORE trials, but also result potentially in the future into a greater accessibility to this new strategy, not only in our countries, but globally and around the world, allowing for, I would say, a more spread over benefit from this strategy around the world. Let's start with the development of these checkpoints. We keep in mind that every new strategy usually starts its development in late lines of treatment where the treatment alternatives are not very satisfactory. It was the case for all of these checkpoints. Pembro, Nivo, atezolizumab have been developed as second-line treatment in the context of randomized trial. Moving later on to frontline strategies, we will cover it as monotherapy, as combination IO-IO, or as combination IO chemo. And as you have been seeing already in evidence, immunotherapy, namely durvalumab, is a standard of care in the curative setting of stage 3 non-small cell lung cancer after chemoradiation. So as you can see on this timeline, an extremely fast development of a new strategy, I would say never met in the past with any of the oncology strategy you might have been testing. Basically, this is also a picture that we have to keep in mind. Every year brings its, I would say, very important load of new trials. And this is about 2020, where this is 724 new combinations that can be described. It's his usual Nature paper. And as you can see here, maybe if one topic is very exciting to the community, is a combination with radiation, with chemo, of course, but also with anti-oncogenic compounds being VEGF inhibitors or VEGF receptor inhibitors, which we will see across many cancer types in the future. Of course, if you think about this new combination, we have to keep in mind that the basic and the skeleton of all of these combinations remain a backbone of anti-PD-1 or anti-PD-L1, mainly and across trials and diseases. But this is combined with many types of strategy from, of course, as I was telling, anti-angiogenic drugs, and here you have some examples, radiation, DNA damage repair-oriented drugs, antibody drug conjugates, epigenetic modifiers, bispecific antibodies, novel modalities, including a series of vaccine, and of course, novel checkpoint inhibitors, checkpoint stimulators, so combination on the backbone of PD-1, PD-L1 inhibition. On the right-hand side, you will see this new landscape of maybe new backbone, which might be not only anti-PD-1 or anti-PD-1, but bispecific immuno-oncology antibodies targeting the moiety of PD-1, but also potentially another target. And this bispecific immuno-oncology antibodies can further down the road be combined with anti-angiogenic, with chemo, and so on and so forth. And we are seeing these antibodies being developed nowadays already in phase 2 and some phase 3 trials. So let's go back to lung cancer and beyond these principles. I'd like first to discuss IO only, meaning IO monotherapy or being IO combinations in the context of frontline non-small cell lung cancer. So first of all, we have been seeing and validated and confirming the role of monotherapy pembrolizumab frontline versus chemotherapy in more than 50% PD-L1, meaning more than 50% of the tumor cells expressing PD-L1. In this specific context of TC more than 50%, we have been seeing at the ESMO meeting a doubling in 5-year overall survival from 16 to 32%, which is absolutely amazing in the field of non-small cell lung cancer. It's quite important to see that these data have been confirmed, and it's very consistent and it's reassuring with another trial, the EMPOWER-1, presenting at ESMO, which was evaluating cemiplimab in more than 50% TC expression. And as you can see, a hazard ratio of 0.57 in described, very promising too, maybe slightly improved as compared to KEYNOTE-24, because this trial was focusing only on patients who had a previous and past history of smoking, right? But basically, very reassuring that cemiplimab, with a shorter follow-up, of course, is showing the same thing. What about atezolizumab? So as you remember, the development of atezolizumab was using a slightly different staining for PD-L1, of course, focusing on more than 50% PD-L1 on tumor cells, but also adding this subgroup of patients with more than 10% of immune cells being positive for PD-L1, meaning that basically per protocol, the subgroup subgroup analyzed is not the same as the two others I have previously quoted. Nevertheless, the trial was showing consistently a benefit of atezolizumab versus chemotherapy. However, the specific subgroup of more than 50% on TC is a post-hoc unplanned analysis, but is converging, as shown by Roy Herbst at the ESMO IO last year, is converging and showing the same kind of result. But again, formally, the level of evidence is slightly lower because of PD-L1 testing. What is interesting with the 5 year data of KEYNOTE-24 is just to think about maybe coming back to our melanoma colleagues, thinking about being cured. Do you mean being cured by having this nice long-term survival data? So basically, just let's look together at this data. On the left-hand side, we all keep in mind that in KEYNOTE-24, all patients stopped the drugs stopped the pembrolizumab at 2 years, right? And now down the road, we are able to see what happens to this patient having stopped at 5 years. So on the right-hand side, the good news is that 81% of them are alive 3 years down the road after having stopped. But not 100%, 81, right? But if you look in the little letters in blue, what is quite interesting is down the road, 3 years after having stopped, 54% of these patients have progressed. So under anti-PD-1 or anti-PD-L1, there is a continuous loss of the patient from the PFS curve, meaning that this kind of cures that might have been observed in complete responders in melanoma might still not be the case in lung cancer, and maybe a component of CTLA-4 might be, again, based on melanoma, a way to stabilize this plateau. But this is just a hypothesis. Of course, this threshold of 50% is interesting, mainly because this doesn't work under 50%. On the left-hand side, you have the attempt of nivolumab versus chemo in more than 5% TC expression, which was not showing a superiority. On the left-hand side, still the MYSTIC trial with durvalumab in more than 25% on tumor cell, which was not showing superiority. On the right-hand side, KEYNOTE-42 in the 1 to 49%. And on the right-hand side, still the IMpower 110 in everything which is under the TC3, IC3, which still don't show a benefit. So 50% threshold is correct, but not under. Let me continue with potential immuno-oncology strategies only. I like the TIGIT checkpoint as being an interesting target across many diseases. And as you know, anti-TIGIT drugs are being developed in many disease types. So basically, TIGIT works at 3 different levels in 3 different ways in order to impact the immune response. The first one is the fact that the interaction of PVR on tumor cell and TIGIT on T cell or NK cells directly leads to an inactivation of T cells and NK cells, inhibiting their proliferation and their activation. So second mechanism is the same interaction leads to the secretion by dendritic cell and antigen presenting cells on cytokines, which mainly leads to a negative immunomodulation like TGF-beta and IL-10. Last but not least, PVR and TIGIT interaction represents also a direct competition for PVR to binding to CD266, which is very important to maximize the activation on CD4 and CD8 T cells. So there are 3 mechanisms by which TIGIT is a good target. Inhibiting TIGIT might lead to a better immune response. What about you? We all would like to measure TIGIT on the T cells to be sure that it is a good target in the tumor type you'd like to treat. Unfortunately, there are still some limitation in TIGIT staining. However, what was shown, it's highly probable, even if not all data show it, but it's highly probable that TIGIT expression correlates also with PD-1 expression, at least in many tumor samples. So there is this trial from Roche Genentech, which is trying to combine TIGIT and atezolizumab. It's a proof of concept trial versus atezolizumab frontline. In this trial, only patients with positive PD-L1 were enrolled, naive to any treatment, and they were stratified by 1 to 49 versus more than 50% tumor cell expression of PD-L1, also stratified by histology and tobacco use. The primary endpoint, again exploratory, was response rate and PFS, okay? This is the bars of response rate and the ITT PFS. So let's start with the ITT PFS. Very interesting hazard ratio of 0.58, which looks like very promising. Let's look at the response rate and be very objective with me. The response rate is improved, but it looks like the whole benefit is only brought and carried, driven by the more than 50% PD-L1, which potentially makes sense about the expression of TIGIT. And if you look at the PFS curve, indeed, this more than 50% PD-L1 is amazing in terms of improvement with a hazard ratio of 0.3, with no difference in PFS being seen in the subgroup of 1 to 49. Last but not least, this treatment is well tolerated with some fatigue, prurite, rash, and arthralgia, but of low grade, maybe some lab tests to be checked, but basically a very nice concept, and a proof is still needed, of course. There is a skyscraper 01, which is ongoing, and as you would have imagined, is performing the evaluation of tiragolumab plus atezolizumab versus atezolizumab in patients with more than 50% PD-L1. Let's look at another strategy of IO-IO combination. It's an old story and an old song, but at the ASCO this year, we're able to see the 3-year follow-ups of the 227. And remember, the arm we look at in 227 is nivolumab and low-dose ipilimumab, 1 mg per kg every 6 weeks, versus chemotherapy. You remember in this complex trial, there were 2 exploratory arms in PD-1 positive and in PD-L1 negative subgroups that we will also look at, but just by curiosity, if you accept this expression. And we also keep in mind that this trial was statistically designed only to answer to the question of superiority of nivo-ipi versus chemo in positive PD-L1 subgroup. And this is due to the accumulated knowledge, I would say, which has probably misled a little bit the community in the beginning. So let's look at these curves at 3 years. So in the positive PD-L1, the primary endpoint of the trial, there is a hazard ratio of 0.71 in favor of nivo-ipi versus chemo. Very interesting plateauing that time with the CTLA-4 component, and very striking difference. Keep in mind something we don't like so much is the early crossing of the curves, the early deaths, which is still observed in the first 6 months of exposure to IO-only strategy in lung cancer as compared to chemo. The exploratory arm of nivo-only, as you can see here, is sitting somewhere in between, so showing the component of CTLA-4 adding something here. On the right-hand side, the negative PD-1 cohort, which was an exploratory cohort and not the primary endpoint. And as you can see, even a better hazard ratio of 0.64. And again, the exploratory arm here of nivo chemo sitting in between. Please believe me, the nivo-ipi curve is completely superimposable in positive and negative PD-L1. The only change between the two curves is the chemo arm, which is moving. So basically, a strategy which is FDA approved only in positive per protocol, none is EMA approved, and the negative cohort does the same, performs the same, but is not approved by regulatory authorities to date. If we keep in mind this benefit here, I just would like maybe to drive you through one additional curve. This is the brain story. Remember that in melanoma, what we have been observing over time is the fact that what might be very active for brain lesion, brain mets, is on one hand TKIs, but on there's a dabratran-tremi. But on the other hand, it can be the immunotherapy, but mainly provided that there is a CTLA-4 component. So in melanoma, ipi-nivo does way better than pembro or nivo monotherapy. Is it the case in lung cancer? We still don't know, but we have this 227 data as separated by brain mets, patient with brain mets, patient without brain mets. And interestingly, remember in 227 patient could have brain mets, but they had to be treated and asymptomatic. But basically, the hazard ratio looks like to be better in patient with brain mets as compared to the subgroup without brain mets, and still as compared to the standard arm of chemotherapy, supporting potentially the activity of CTLA-4 in the brain. And of course, what we like is this response-based assessment. So if you look at the patients who are in response at 6 months, are still in response at 6 months, you can see how their survival curve look like in PD-1 positive cohort, in PD-1 negative cohort, amazing curves, right, showing bit like Hodgkin disease, a very long-term benefit. If you have a response, suddenly your patient sits on a very different survival curve. Let's have a look on IO chemo. This year was not really showing new data, but we have to keep in mind this data, and particularly the fact that a little bit in an opportunistic way, but also supporting by some clinical data, or I would say preclinical data, translational data, we have been combining chemo and IO in non-small cell lung cancer. When I say some biological rationale, it is about this immunogenic cell death, the fact that some chemotherapeutic agents might favor a more visible cancer cell death in front of the immune system, favoring the specific T cell response, and also in some preclinical model, some aspecific, for example, neutrophils response based on some drugs, which hopefully and fortunately we are basically using in non-small cell lung cancer treatment. So we have this table of all the positive trials in terms of predefined endpoints, combining chemo and IO. In green, the non-squamous trials where pembrolizumab and chemo is better than chemo, where atezolizumab, bevacizumab chemo is better than bevacizumab chemo, and where atezo chemo is better than chemo in IMpower 130, but unfortunately using nab-paclitaxel. I make this precision because of the breast cancer, you remember, story, and in many countries, nab-paclitaxel is not used in lung cancer. In blue, the only to date squamous cell carcinoma trial showing that pembro chemo is better than chemo. And here the chemo was a taxane-based, whichever taxane-based regimen. So basically, this is what is now standard of care. And this is what the curves look like. I took the example of non-squamous, Kinon 189 with a really long-lasting benefit, no initial crossing of the curve sent to the chemotherapy, and IMpower 150 with the atezo component, also a very interesting hazard ratio of 0.78. Maybe not the benefit you would expect by adding such a complex regimen of 4 drugs, but still a significant benefit. So let's look at this year data at ASCO, the dual IO chemo. So you put everything together. And this is the basic of a very clean, as compared to 2279LA study, naive patients, no EGFR mutation, no ALK mutation, a good performance status, patients stratified by positive versus negative PD-L1 patients, but all can be enrolled, stratified by sex and stratified by histology, squamous versus non-squamous. These patients are randomized 1-to-1 to usual chemotherapy, histology-based chemotherapy, allowing for maintenance pemetrexed in non-squamous, as compared to a very interesting regimen of 2 cycles of chemo combined with nivo-EP, with EP low dose, flat dose nivo that can be given every 3 weeks in parallel to chemo. And this nivo-EP is continued until progression or up to a maximum of 2 years. So only 2 cycles of chemo, and as compared, plus nivo-EP as compared to chemo. Primary endpoint, survival. This is quite a short follow-up. Now we have a little more than a year of follow-up, but as you can already see, there is a nice hazard ratio of 0.66, the suspicion of a nice plateauing of the curve, and as you can see too, we can stay away from the crossing of the curves. Does it mean that this excess of death is related to an initial immunogenic effect of the chemo, or just gaining some time for the immune response to really be mounted and act on the tumor in order to prevent the early progression and death of high tumor burden patients? We don't know, but no crossing of the curve. This benefit was observed across all patient subgroups, and I'd like you just to have a look again at this interesting effect on patients with treated asymptomatic brain mets at baseline. And this led to this new and updated version of the living guidelines on the ESMO website, where all of these options are shown as being available, and of course are also scored with a level of evidence, a degree of recommendation, as well as a magnitude of clinical benefit scale, MCBS score, for all of these potential opportunities you have. And if you want to summarize, I guess that in patients with squamous or non-squamous histology, you have many options to choose and to decide for all lung cancer specialists. Of course, in non-squamous, you need to exclude an actionable driver frontline, but if not present, I think you have this IO-IO combination, IO-IO chemo combination, which are available. And I think restricted today to the more than 50% PD-L1, you have this option of pembrolizumab, to a lesser extent atezolizumab, which still represent a kind of a happy opportunity, a nice opportunity for patients in that specific setting. Of course, there is still this question about the more than 50% to know if you should give only Pembro, Atezo, or you should give chemo IO or chemo IO. And this is, of course, a question where we don't have the answer yet. And probably the 5-year overall survival will give us the answer, and of course the patient preference too. But if you just look at the response rate in this specific more than 50% PD-1 on tumor cell, you can see that probably the highest response rate are seen with combination being IO chemo or IO chemo, which leads to potentially the idea that combination chemotherapy with chemotherapy might be useful in patients with potential aggressive disease, symptomatic disease, high tumor burden, which is probably what we use in the clinic today to make our decision. Let's look at chemoradiation and IO for locally advanced non-small cell lung cancer. You remember the strong rationale, again, for combining radiation and immunotherapy, where radiation-induced DNA and membrane damage leads to some cytoplasmic reactive oxygen species, which will activate many transcription factors, will improve the presentation to the immune system, and will positively modulate a specific immune response as a kind of immunogenic cell death again. It has been nicely shown in preclinical mice models that basically if you try to give radiation and IO, this will be efficient and even more efficient if you do it concurrently as compared to sequentially, something which we start to adapt, as you will see in the context of patients' treatment. But basically, thinking about the sequential administration of radiation and IO, we had this year at the ESMO meeting the 4 years follow-up data of Pacific. Pacific was giving 1 year of durvalumab in all patients with stage 3 disease, having received chemo radiation before at least 50 grays, at least 2 cycles of platinum-based chemotherapy, and the durvalumab was given for 1 year. I think these 4 years follow-up data are amazing, with an improvement of 13% overall survival, a hazard ratio of 0.71. So really, first of all, wonderful absolute median OS data, up to 48 months for the durvalumab arm, but also a very significant long-lasting improvement for durvalumab. It's quite important to keep in mind that this benefit was seen for OS and PFS, regardless of the usual categories, prognostic and predictive categories looked at in non-small cell lung cancer. So a benefit seen across a group of patients. And when you think about biomarkers, it's quite important to keep in mind that as a post hoc unplanned analysis, the EMA has decided to only allow the prescription of durvalumab in positive PD-1 patients. And as you can see here, this was based on the fact that despite the intervention per se, so the PFS was improved in PD-1 positive and negative patients due to really a shift which was shown as a prognostic impact. The overall survival was only seen to be beneficial in PD-1 positive patient. And again, here what was moving in this OS was not the durvalumab treated arm, but the standard arm, right? And again, it's the post hoc subgroup analysis. But because of this OS, this strategy is only available in many countries in positive PD-1 patients. So again, we have to keep in mind this is a huge limitation also because many patients had no test being performed in Pacific. And of course, we don't know the value of a PD-1 being assessed before chemoradiation in order to provide durvalumab afterwards. And again, based on the PFS, to me, the strategy should be offered to all patients. Unfortunately, it's the case in Switzerland, but not in Europe. In US, it's the case too. There's no restriction. And this is, I would say, probably true in facing right interpretation of statistic as it should be done in all subgroups analysis by any regulatory authority. How can we move in stage 3? So of course, we have to consider all types of strategy. First of all, can you move Pacific to a very frail category of patients? So maybe skipping chemotherapy. So this is being assessed with only radioimmunotherapy maybe to be given in some patients with stage 3 and also in some patients with maybe oligometastatic disease. Of course, then you can move into consolidation immunotherapy beyond the Pacific population. So maybe by doing some sequential or atypical chemoradiation, maybe moving patient characteristic to also some other subgroups like a higher performance status patient, and so on and so forth. Of course, you can reinforce the chemo, radiation, and immunotherapy by variation in timing, giving them concurrently, or even giving a priming immunotherapy before chemo radiation. And of course, you may be innovative in the way you add new immunotherapeutic compounds. The first thing which comes to our mind is CTLA-4, but not only. So, and of course, with potential toxicity growing over time by this specific intervention. And there are phase 3 ongoing trials. I'd like you to understand that there are two very important trials, the Checkmate 73L, which is putting Nivo concurrently to chemorad, and is also proposing a consolidation with Nivo-EP. We have this Pacific 2, which is moving durvalumab directly with concurrent chemorad, but we also have this wonderful bintrafusp alpha strategy, where you have this dual, this bispecific antibody targeting TGF-beta and PD-L1. This is a kind of an avelumab moiety, which will be given concurrently to chemorad, followed by bintrafusp alpha versus the Pacific arm. And of course, there are many other small trials evaluating other treatment options, their safety profile, and opportunities in the field of non-small cell lung cancer. Are we going to move or to change the paradigm of surgery in resectable non-small cell lung cancer? So basically, why we have been showing in the past that giving chemo in the adjuvant or neoadjuvant setting is more or less equivalent. It was in the NATCH trial published by Enriqueta Felipe and colleagues. We also have been showing that the only difference is a little better compliance, a better treatment delivery in the neoadjuvant setting as compared to the adjuvant setting. But why would immunotherapy be different in the neoadjuvant or in the adjuvant setting? Would it be beneficial? So basically, because of, I would say, immunological paradigms. First of all, before any treatment, where the tumor is in place and is untreated, you have probably a higher antigen load and potentially a higher opportunity for antigen release from dying cells in untreated tumor. So you have an opportunity to better prime the immune system. Before surgery or before any intervention, the immune system of the host is certainly fitter. Looking at Charlie Swanton data, what we call the clonal evolution, so the heterogeneity of the tumor over time, is probably minimal in the neoadjuvant setting. And of course, you have an opportunity to accurately study the effect of IO pre and post the intervention, meaning at the biopsy and in the surgical tissue at the time of surgery. And of course, you have an opportunity to assess clinically and radiologically the efficacy of your therapy during the neoadjuvant treatment. Thinking about the neoadjuvant strategy, we had this preclinical models, mice model, showing the benefit of neoadjuvant immunotherapy as compared to adjuvant immunotherapy, being in breast cancer or in lung cancer, with a prolonged survival with neoadjuvant IO, an increased level of tumor-specific CD8 positive T lymphocytes, and a decrease in tumor spread, including lung metastasis, by using neoadjuvant as compared to adjuvants. So basically a promise for clinical daily practice, but also a challenge. And we are discussing in the community how also to move fast in this field, potentially by using surrogate endpoints. So in breast cancer, our colleagues have been using in the past pathological complete response as being a potential surrogate biomarker for survival after surgery. And this has been accepted by the regulatory authority in breast cancer with, for example, the FDA approval of pertuzumab regimen based on pathological complete response. Unfortunately, in lung cancer, pathological complete response are quite rare, being observed between 1% and 5% of the patients after neoadjuvant chemotherapy. Another option would be to potentially use MPR, major pathological response, which is defined by less than 10% of viable tumor cells in the surgical sample. It has been shown to occur in more or less 20% of patients after neoadjuvant chemotherapy in at least 3 publications, and to be correlated with overall survival. However, none of these pathological endpoints has been envisaged and proven to be a surrogate of survival at the era of immunotherapy, and might not be accepted by any regulatory authority. About neoadjuvant IO, we already had the proof of concept with this initial New England Journal of Medicine publication of 2 cycles of nivolumab in the neoadjuvant setting, basically showing that after 2 nivolumab only, you observe a massive influx of CD8 positive and PD1 positive immune cell in the tumor. And this is the table showing you all the trials, small phase 1-2 trial, having assessed immunotherapy only as a neoadjuvant regimen before surgery. And I'd like you to look at 3 columns, sorry. The first one is the N, just with a word of caution about the small numbers of this trial. And the 2 other columns are the improvement in what was expected as major pathological response from 20 to up to 30, even 40%, and a doubling or even a tripling of the pathological complete response, where you can see here some ranges between 8 and 20% just by using neoadjuvant IO without chemo. Adding chemo looks obvious after what we have been doing in stage 4. And here we have trials also performing chemo IO, using chemo IO in the neoadjuvant setting. And 2 have been published. The proof of concept NADIM is focusing on stage 3A disease. Remember, stage 3A is more or less 30% to 40% survival at 5 years. 3 cycles of chemo nivolumab surgery, and an amazing major pathological response rate of 83%. And you will agree with me, amazing PFS and overall survival curve. So second trial using atezolizumab with 4 cycles of chemo is also showing an amazing DFS and OS curve. Majority of these patients were stage 1B to stage 3A, but majority was stage 3A with 77% of them, so locally advanced disease. And all of them almost could go to surgery. This is the neoadjuvant chemo IO trial summary. Again, a word of caution because of the small n, and a very, very interesting and exciting MPR rate ranging from 57 to 83%, and the pathological complete response amazingly moving from 15 to 60%. Really promises for chemo IO more than IO in the neoadjuvant setting, again, because you need to bring all of these potentially curable patients to surgery and not fail in this important step. There are 3, of course, major neoadjuvant trials, 4 trials, 4 pharma companies, nivolumab, atezolizumab, pembrolizumab, durvalumab. All of these 4 trials have a primary endpoint of event-free survival, which is usually considered as a decent surrogate endpoint for OS, and some other endpoints, including pathological endpoints. And as you have probably heard by press release, Checkmate 816 have been announced to positively and significantly improved pathological complete response by adding nivolumab to chemotherapy versus chemotherapy. And we are looking forward to see this data. Of course, keep in mind that neoadjuvant looks very promising. There are also adjuvant trials ongoing. Again, 4 pharma company, 4 trials at ISO, Nivo, Pembro, Durva, with all having this decent primary endpoint of DFS in this curative setting, and a generation of new trials trying to understand who are the patients who should receive, in addition to surgery and chemotherapy, immunotherapy. In an exploratory fashion, in Alchemist, you're looking at circulating DNA as being a potential predictive factor for the need of adjuvant IO, and in a prospective fashion in Mermaid-1, where the primary endpoint is targeting minimal residual disease positive patient using a private signature and randomizing adjuvant durva in the addition to standard of care. So very interesting data to come. I just wanted to dive with you with this open question about, is there any question to keep in mind about compatibility of immunotherapy and radiation in stage 3 in the adjuvant setting? Remember that based on some improved local control, some indirect evidence of survival benefits, and in retrospective series, including the SEER database, many centers were given adjuvant radiation in patients after surgery and chemo in stage 3A and 2. Unfortunately, I must say the most recent series were not showing a benefit, and we couldn't show a benefit in the neoadjuvant setting. However, radiation was still part until ESMO meeting of stage 3A curative intent treatment. And at the ESMO meeting, the long art trial randomizing completely resected stage 3, having received chemo and surgery to radiation or not in the adjuvant setting, was showing this non-significant DFS curve, this non-significant survival curve, basically a reduction of mediastinal relapse using PORT, a non-significant difference in 3-year disease-free survival using PORT. However, a higher rate of death as first DFS event in the radiation arm, and basically an increased risk of mortality in the radiation arm. So in stage 3, no reason to question the compatibility of IO and radiation, because radiation should simply not be given anymore in that context. Let's move to targeted therapy for advanced non-small cell lung cancer. This is the usual pie of non-squamous non-small cell lung cancer with the actionable genetic alteration and a growing list of all the new compounds to try to find an alternative to chemo or chemo IO. This is the start. Let's start with EGFR. We remember this survival in benefit being seen for osimertinib versus the first generation gefitinib or erlotinib frontline, which translates in a 9 months benefit in overall survival. Of course, the next question is what happens upon osimertinib resistance? So mainly on target modification of EGFR secondary mutation, mainly the C797S mutation, in family mechanism with HER2 amplification or mutation, and bypass tracks, mainly including MET amplification. So let's think about resistance to osimertinib. We had a very nice publication, phase 1b trial of using osimertinib and savolitinib, a MET inhibitor, in patients who are resistant to any generation of TKI, including new generation of TKI. And you can see the very interesting response rate of these patients at resistance to EGFR TKI. And if you look at the older data of gefitinib and capmatinib in patients being resistant to EGFR TKI and showing a high expression of MET, again, a very nice mechanism of action. So potentially, I would say, being a little rational in the way we perform personalized oncology, when a MET amplification is defined as being the mechanism of resistance, the addition of a MET inhibitors looks like being a strong option. Another option to target MET is this amivantamab bispecific antibody targeting EGFR and MET. And as you can see here, we had first a data presentation at ASCO meeting where patients with variable EGFR mutation and variable mechanism of resistance to EGFR TKI were given this amivantamab and a nice response rate of 30%. And basically a sequence series shown at the ESMO meeting combining amivantamab with lazertinib, which is like osimertinib, a third generation EGFR TKI, looking at patients exposed or not to osimertinib, but resistant to an EGFR TKI, showing a very nice response rate of 36%. So there's a room to continue to develop amivantamab, maybe as primary treatment, but basically mainly at resistant treatment upon any EGFR TKI, and trials are ongoing. About the in-family mechanism of action, remember this ERB1, 2, 3, 4 family. We have been seeing in the graph before that HER2 amplification is a known mechanism of resistance, but we also know how much HER3 might, by secondary dimerizations, reactivate the PI3 kinase signaling pathway and might serve as a partial mechanism of resistance to EGFR TKI. And we have this interesting drug, the patritumab deruxtecan, the U3-1402, which is an antibody drug conjugate targeting HER3 with payload of topoisomerase 1, which has been assessed first in a set of EGFR mutated non-small cell resistance to any TKI, with an expansion cohort even slightly larger for all patients being exposed to chemo and TKI. Basically, no biomarker was needed there, but it was shown that most of these resistant tumors expressed to a high level HER3. And here in this trial, stable brain mets were allowed. And I just would like you have to go through this publication, but to show you this response rate of 25%, a median duration of response of 6.9 months, a nice waterfall plot. And here you have the description of the co-occurring mutation, which can be very important, the EGFR mutation, and the toxicity profile. Keep in mind, the development of this drug is continuing and also in combination and in late lines, but 5% ILD, inflammatory lung disease have been observed. A little word of caution here. And we have to keep in mind IMpower 150. Remember, IMpower 150 is the only strategy which has been showing a real benefit in EGFR mutated non-small cell lung cancer using immunotherapy. And as you can see, in the middle graph, maybe, when you want to get a benefit from immunotherapy with chemo, you need to use also bevacizumab, the left-hand side panel, because the benefit is not seen with atezo chemo versus bev chemo on the right panel. So maybe the first line of chemo might be a first line of chemo IO bevacizumab in this specific EGFR mutated non-small cell lung cancer. An update has been published and discussed at the ESMO Congress again. Let's read to ALK. At the ASCO meeting, we were able to present and shortly after publish the 5-year overall survival of the ALEX trial, alectinib versus crizotinib, with, as you can see, the overall survival data remaining immature, with at the time being 37% of the events being recording, but today a stratified hazard ratio of 0.67, which of course is still not final, but looks like to be and will remain statistically significant. The median OS was not reached still at 5 years with alectinib and was 57.4 months with crizotinib. So amazing data for alectinib. We have been seeing new ALK inhibition data at the ESMO meeting with this expected CROWN trial, the last phase 3 trial comparing lorlatinib to crizotinib. And as you can see here, an amazing hazard ratio of 0.28 is found in favor of lorlatinib. Based on the mechanism of action of lorlatinib, which is considered to be one of the most potent ALK inhibitor on the brain at the CNS level, we'd like to just focus on this comparison of lorlatinib versus crizotinib in terms of response in measurable versus non-measurable, 66 versus 20%, and in measurable, 82 versus 23%, really favoring lorlatinib. We also know that lorlatinib has a toxicity at the brain level, which has to be considered in terms of mood and intellectual capacity. When you compare this data of lorlatinib to the other data which were described, with the other compound, alectinib and brigatinib, you can see that basically this data favor in terms of response rate, but also in terms of complete response, favor equally or slightly better than alectinib, brigatinib, but today it's very difficult to find an obvious difference. And if I just want to give you one data, intracranial responders in patients with measurable brain mets is 82% for lorlatinib, is 81% for alectinib, and is 78% for brigatinib. So again, we need some more data to be able to understand the role of each of these compounds, reminding and keep it in mind that lorlatinib might be a good option at resistance to alectinib or brigatinib that has been shown in the published data of lorlatinib previously. Let's look at RET alteration. RET alteration can be mutation, mainly in medullary thyroid cancer, and can also be RET fusion, which are found in maybe 2% of non-small cell lung cancer. RET fusion can be assessed, usually are assessed by NGS or by RT-PCR. We have to keep in mind that every strategy you use, and particularly when using immunohistochemistry, false negative and mainly false positive patients can be documented. So the way you document RET fusion by RT-PCR, by FISH or by NGS is crucial in making sure that your diagnosis is right, because the incidence of RET fusion is very low, more or less 1% in non-small cell lung cancer. We have data. This is a slide that was shown by Benjamin Bess at the ESMO meeting of the old days multikinase RET inhibitors, vandetanib, cabozantinib, and lenvatinib in small series, with response rate ranging from 16% to 47%, but still also with the range of toxicities that might sometimes characterize less specific TKIs. And of course, more than everything, this all TKIs are competed, I would say, overpassed by the new specific RET inhibitors, selpercatinib and pralsetinib, the LOXO292 and the BLU667, which have been showing, as you can see, response rate of 64% and 55% in patients after platinum-based chemotherapy, and 85% and 66% in naive patients. So really, amazing data having led to the registration in many countries, including FDA. In terms of resistance, and to be very fast, we have been describing on-target resistance. And as you can see on this slide, the emergence of multiple mutation in this case report in the red solvent front, and also off-target resistance, which were basically the combination of on-target solvent front, but also MET amplification in 3 cases here as resistant mutation, showing the importance of being able to target MET. Of great importance, selpercatinib and pralsetinib are not efficacious, are not active when RET mutations happen at the solvent front and at the hinge. Interestingly, these they have an unconventional modes to bind to RET that avoids the interference from gatekeeper mutation, but is vulnerable to non-gatekeeper mutations. So basically, really defining the need for new treatment strategies at resistance to both of these amazing compounds. Let's move to NTRK fusion. Remember, NTRK fusion are extremely rarely observed, including in lung cancer, where it can potentially be described in 1% of non-small cell lung cancer, but also in many other disease types. Larotrectinib has been assessed in many disease types, and including lung cancer. These are the lung cancer data with an interesting 14% small subgroup being observed with a PFS curve that you can see here, 1 year, 70% PFS, and the response rate being evaluated as 64% in all patients and 57% in patients with CNS metastasis, suggesting an effect of this drug at the CNS level. Indeed, when you look at the whole cohorts of patients across diseases treated with larotrectinib, by the way, very nice waterfall plot, in the 14 evaluable patients with brain mets, the investigator assessed response rate was 71%. Okay, let's look at entrectinib. These are the data across cancer types for NTRK fusion. Overall response rate 57%, PFS was 11 months. So again, very nice data for this compound. If we try to compare what we have today, it's quite interesting to see that the response rate of both of these compounds is comparable between 60 and 70%. The PFS reported today looks like to be slightly longer for larotrectinib, but again, remember, very variable patient populations, very variable, and very small number of patients. So really limited in the comparison, and waiting for both compounds for prospective large number, looking at intracranial responses, but a signal for efficacy has really been observed with both compounds. Of course, it's interesting to look at the resistance. So first of all, some of the resistance are acquired through the acquisition of on-target TRK kinase domain mutations, interfering with drug binding, potentially allowing to give a room for next generation, secondary generation TRK inhibitors like repotrectinib and selitrectinib. Of course, it can also happen through mutations stabilizing the inactive conformation of the kinase, giving a room back to the type 2 TRK inhibitors, very interestingly, like cabozantinib, foritinib, and ponatinib, so allowing us to understand or to have new treatment options. And of course, there have been described bypass track off-target resistance mechanism, mainly here affecting the MAP kinase pathways, where some drug combinations could also be envisaged. Let's look at ROS1. Remember, ROS1 rearrangements leads to a constitutive activation of the dimer, mainly signaling through the MAP kinase pathway and the PI3 kinase AKT pathway, as you can see on this scheme. We have been seeing in the publication, the recent publication in Lancet Oncology, that lorlatinib can be very active in ROS1 patients being naive or pretreated with crizotinib, with respectively response rate of 62% and 35% in the brain of 64% and 50%. Repotrectinib, the same thing, can be active in patients pretreated or naive, with in naive 82% response rate, 39% in pretreated, and in the brain 100% in naive and 75% in pretreated. So very strong components. And entrectinib is also active in ROS1 positivity, response rate 77%, and intracranial response rate of 55%, and a PFS of 19 months has been described in this very interesting publication of Drillon and colleagues. Of course, resistance to ROS1 TKI uses the same mechanism. So bypass activation, it was mainly EGFR and KIT or secondary point mutation, which can be G2032R or other set of mutation there, which present with variable sensitivity to all the inhibitors of ROS that we have in our hands. And interestingly, in terms of solvent front substitution, it's interesting to describe that there is a parallel between the ROS1 G2032R and TRK-A, as well as ALK solvent front substitution, showing the similar mechanism of resistance. Of course, this table of in vitro kinetic inhibition can lead to some suggestion in terms of secondary point mutations. And for example, lorlatinib, if you really think about the specific point mutations, has been shown to be active, at least for some of them, being composite or not, in these publications that I invite you to go through. MET has become also an interesting target, looking at this MET exon 14 skipping alteration, which basically alter the degradation and leads to the accumulation of MET proteins in the cell, which has been observed in 3% of non-small cell lung cancer. We have this in vitro kinetic showing that we have basically in our hands many MET inhibitors, which might be very active in MET exon 14 skipping mutations, right? And we have data leading to the registration, at least in some countries, of two very important MET exon 14 inhibitors, the capmatinib in geometry trial, with response rate in 41 and 68% of pretreated and naive patients. You have the PFS down on the left. And in, of course, interestingly too, but potentially to a lesser extent, capmatinib was also active in MET amplification. Remember, the definition of MET amplification is tricky, but to a lesser extent with something like 30 or 40% response rate. But let's focus on the MET exon 14 skipping mutation, where tepotinib has also led to a registration in some countries and a response rate of 46%. If you compare capmatinib and tepotinib, be careful, we shouldn't do that, but we do that. Response rates are more or less comparable, but maybe slightly in favor of capmatinib with 68% versus 44%. Duration of response look to be the same. A PFS look to be slightly better for capmatinib, but again, be careful with this comparison. Both compounds are very active. Side effects are mainly and importantly related to MET inhibition with GI toxicity, as well as the development of edema. Resistance mechanism are to date still poorly described, but if you look at the resistance mechanism of capmatinib, it has mainly described to be some secondary mutation, but more importantly, bypass tract, including and impacting the EGFR with amplification and HER3. Last but not least, the undruggable KRAS. So KRAS has become now a new target in specific KRAS mutation in non-small cell lung cancer, to a lesser extent also being evaluated in colorectal cancer with less of a success. Remember that in adenocarcinoma, up to 30%, 25-30% of KRAS mutations can be observed, the majority of them being G12C mutation, 42% in this series. And we have the sotorasib data, CodeBreak 100, which has been describing the activity in pretreated patients and a response rate of 32% and a progression-free survival of 6.3. So interesting data, but rather for a second-line treatment, competed by the adagrasib data, Kristan-1 trial, showing a response rate of 45%, still no PFS, but a duration of response of 8.2 months. So also very interesting data. These both drugs are being developed in late lines and in combination frontline, and will let us know a bit more in the future. Last but not least, adjuvant therapy in oncogene addiction, a matter of debate because EGFR TKI have been evaluated in the adjuvant setting with mainly a DFS, but not an OS benefit through a series of clinical trials. Some of them were not addressing specifically EGFR mutation and have been looking at it in a retrospective fashion and post hoc unplanned analysis, but none of them were able to show an overall survival benefits. Particularly, one trial has to be discussed, the adjuvant CTONG 1104 trial, which was focusing on EGFR mutated patients, was showing a huge benefit in DFS of gefitinib versus adjuvant chemotherapy, but didn't translate into a survival benefit. So basically, trials have to date been limited by design and by the size. No OS benefit demonstrated to date. It is still unclear if adjuvant EGFR TKI therapy results in cure of some patients, like mainly or maybe described in melanoma in the recent New England Journal of Medicine, or only delays recurrence. And of course, we have no evidence of appropriate sequencing and even duration of treatment. However, AstraZeneca has this year challenged this concept by adding osimertinib to standard of care surgery and chemotherapy, adjuvant chemotherapy in early non-small cell lung cancer with EGFR mutation. And as you can see here, It has a trial which had a primary endpoint on stage 2 and stage 3 according to the 7th TNM classification, and the benefit of DFS has been observed in all of the stages, including stage 1B, with hazard ratio ranging from 0.5 for stage 1B, 0.17 for stage 2, and 0.12 for stage 3 regarding DFS for osimertinib versus placebo. Exciting data. Will it translate into overall survival is the main point of debate. What we could see at the ESMO meeting is this estimated probability of observing CNS recurrence, of course, in the absence of another event at 18 months, which was less than 1% in the osimertinib arm versus 9% in the placebo arm, really showing that to complete the, I would say, very important impact on DFS, you have a very important preventive effect at the brain level, knowing the high prevalence of brain events in this specific patient population. So is it enough to convince the oncology community, the caregivers? So I would say the professionals, I would say some of them yes, some of them no. Anyway, we wait for longer term results and we'll see how the community moves with this specific new concept. And this is the snapshot of the overall survival, 5% maturity, already a separation with an estimated hazard ratio at the timing of 0.4. How will it move and change over time is the main question. And I will be very happy to know what you think about it. And with this, I thank you for your wonderful attention.
This is Dr. Stephen Liu, Director of Thoracic Oncology from Georgetown University, and as part of the OncoAlert Colloquium, I'll discuss systemic therapy for small cell lung cancer. These are my disclosures. Bit of background. By the numbers, small cell lung cancer is a less common but disproportionately lethal subtype of lung cancer. It accounts for about 13% of new lung cancer diagnoses in the US. Note the strong association with tobacco use. It is characterized by early spread, with most patients presenting with late-stage disease, and unfortunately poor long-term outcomes with historic therapy. We stage small cell the same way we stage non-small cell, using the AJCC TNM staging system. However, in the clinic, there's also a more practical working staging system established by the VA Lung Group, where we split small cell into early limited stage disease and later extensive stage. Limited stage, which is less common, is defined as cancer where all disease can be encompassed in one tolerable radiotherapy port, and that is managed with definitive concurrent chemoradiation, typically using cisplatin and etoposide. Despite receiving definitive therapy, most patients will relapse, and the majority of patients with small cell initially present with extensive stage disease, where the treatment is systemic therapy alone, historically chemotherapy, platinum etoposide in the frontline setting, topotecan in the second-line setting. This had been our standard of care for decades, not because they were particularly good treatments. Platinum etoposide, first introduced in the 70s, it is well tolerated, easy to administer, and offers a high response rate, about 60%, with 10% of patients achieving a complete response. But relapse is very common, and the responses are very transient. Progression-free survival about 4 months from the start of therapy, so most patients progressing either during or shortly after chemotherapy, and survival for many decades had been stuck at about 8 to 10 months. If we look at that Kaplan-Meier curve on the right, we see with platinum etoposide, most patients not surviving to a year. We've had few approvals in the frontline space. Carboplatin was approved, but not based on any survival gains. This has been a stagnant standard of care really for decades, despite dozens of randomized trials. While early phase 3 trials showed initial responses, they simply failed to extend patient survival. There was renewed promise with the introduction of immunotherapy. Here was a modality that showed activity across tumor types, where efficacy seemed to be in smoking-related or carcinogen-related cancers, or cancers with high rates of somatic mutations. Those were both features of small cell lung cancer. And so we had high expectations over the next few years we would see activity, though a bit more modest than we had initially hoped. Our first large experience of immunotherapy in small cell was Checkmate 032. This looked at nivolumab alone, a PD-1 inhibitor, or with ipilimumab, a CTLA-4 inhibitor. In the non-randomized cohort, we learned that nivolumab alone offers a response rate of about 10%. Adding ipilimumab increases the response rate, but also increases toxicity. If we look at progression-free survival, it's quite poor. Most patients progressing really at the first scan, but the landmark survival rates were a bit higher than we'd expect. If we look at the Kaplan-Meier curve for the non-randomized cohorts, we can see that at 2 years, a significant number of patients surviving, 14% with nivolumab, 26% with nivo-ipi. While those numbers may seem low, remember for pre-treated small cell lung cancer, we'd expect those numbers to be very close to 0. Here we have 1 in 4 patients surviving in 2 years with nivo-ipi. There's a clear signal here. This was followed up with a randomized phase 2 cohort of CheckMate 032. Patients with previously treated small cell randomized 3-2 to receive nivolumab alone or nivo plus ipi, though note the difference in dosing schedule. This randomized over 240 patients, and what we learned was adding ipi significantly increases response rate from 11.6% to 21.9%, but it also significantly increases toxicity. Unfortunately, it did not translate to an improvement in survival. Median survival and 2-year survival rate numerically larger with nivolumab alone. The addition of ipi did not increase survival and is not part of our NCCN guidelines. But if we look at nivo alone in the third-line setting, while response rate is modest at about 12%, the responses are of high quality. A median duration of response of 18 months, an 18-month survival rate of 20%. Based on the unmet need and the quality of these responses, nivolumab received accelerated approval as third-line monotherapy in August 2018. Similarly, based on 2 single-arm phase 2 trials, Keynote 028 and Keynote 158, pembrolizumab received accelerated approval as third-line monotherapy in June 2019. These are important approvals and good options for patients in the third-line setting, but there's a very high attrition rate for small cell, and few patients receive third-line therapy. As this graph illustrates, of patients receiving frontline chemotherapy, only about 1 in 5 will go on to receive any third-line treatment. Yet these are potentially transformative drugs, and so how do we reconcile that? Drugs that can lead to long-term survival for a significant fraction of patients, how do we ensure those patients just say, receive the opportunity to derive that benefit? How do we increase the impact of immunotherapy? Well, we try to move immunotherapy up. CheckMate 331 explored second-line nivolumab versus chemotherapy, either topotecan or where approved amrubicin. Topotecan, a seemingly low bar, yet surprisingly, nivolumab not able to clear it. No difference in survival between nivolumab and chemotherapy with a hazard ratio of 0.86, a confidence interval that crosses 1. The progression-free survival strongly favoring chemotherapy, hazard ratio of 1.41, and a very steep drop in that PFS curve with nivolumab alone. But perhaps second line is too late. We know that when small cell relapses, it is highly refractory treatment. Can we go earlier? CheckMate 451 looked at patients with small cell lung cancer who had completed platinum doublet chemotherapy, had not yet progressed, and randomized to receive nivo alone, nivo plus ipi, or placebo. Surprisingly and disappointingly, nivo-ipi not faring better than placebo, not improving survival in the maintenance setting. The greatest potential for impact was always in the frontline space, and the first regimen to explore that was atezolizumab with platinum etoposide. There's several lines of evidence to support this. Chemotherapy, we know, can promote antigen release, exposing antigens to antigen-presenting cells like dendritic cells. We know chemotherapy can have a favorable effect on the immune milieu and the microenvironment, suppressing Tregs and myeloid-derived suppressor cells. The high attrition rate would limit the impact of later lines of therapy, and by giving it up front, we can retain those initial benefits of chemotherapy and perhaps lead to a more favorable ratio of tumor cells to immune cells. In addition, at this point in time, we knew that atezolizumab could be safely combined with platinum doublet chemotherapy, and this led to the Empower 133 trial. This was a global, randomized, placebo-controlled, double-blind phase 3 trial for patients with extensive stage small cell lung cancer and included patients with treated asymptomatic brain metastases. All patients received carboplatin AUC5 on day 1 and etoposide 100 milligrams per meter squared days 1 through 3 for 4 cycles. They were randomized to receive concurrent atezolizumab or placebo, followed by atezo or placebo maintenance. This study had 2 co-primary endpoints, overall survival and progression-free survival. And as we know, this study met both of its endpoints, improving PFS and OS and leading to a new standard of care for small cell lung cancer. What we saw with atezo was a modest improvement in PFS with a hazard ratio of 0.77, most importantly, a significant improvement in overall survival with a hazard ratio of 0.70, a 30% reduction in the risk of death, an improvement in the median survival from 10.3 to 12.3, and an improvement in the 1-year survival rate from 38.2% to 51.7%. With more follow-up, we see that the improvement in 18-month survival rate is the same as the improvement in 12-month survival rate. Atezolizumab improved quality of life. Patients receiving atezolizumab had more clinically meaningful improvements in symptoms sooner and sustained for longer than placebo. And importantly, the improvement in outcomes and quality of life didn't come at a significant increase in toxicity. If we look at delivery of chemotherapy, patients received a median of 4 doses of carboplatin and 12 doses of etoposide, or 4 full cycles. The addition of atezolizumab to chemotherapy improves PFS, improves quality of life, and improves overall survival without compromising our ability to deliver 4 full cycles of chemotherapy. Based on these data, atezolizumab with carboplatin and etoposide was approved by the FDA in March 2019 as first-line treatment for extensive stage small cell lung cancer, approved by the EMA in September 2019, and listed in the NCCN as a Category 1 preferred option. We waited almost 4 decades to see any treatment improve survival for small cell lung cancer. We waited less than a year to see the second, and that was the Caspian data. This was an open-label, 3-arm randomized study for patients with extensive stage small cell lung cancer, where patients were randomized to receive chemotherapy alone, chemotherapy with durvalumab, another PD-L1 inhibitor, followed by durva maintenance, or chemotherapy with durvalumab and tremelimumab, a CTLA-4 inhibitor, followed by durva maintenance alone. What we saw was the addition of durva to chemotherapy improved survival to a degree very comparable to atezolizumab and IMpower133. The hazard ratio with durvalumab was 0.75. Durva improved median survival from 10.5 months to 12.9 months. However, the addition of durva with tremi did not improve survival. Hazard ratio here not meeting statistical significance. The addition of durva tremi with durva maintenance did not improve survival over chemotherapy alone. What the addition of tremelimumab did do was increase toxicity. If we look at adverse events leading to treatment discontinuation, it was about 21% with durva tremi compared to 10% with durva and 9% with chemotherapy alone. The third large trial to look at the combination of immunotherapy and chemotherapy was KEYNOTE-604. This phase 3 trial looked at platinum etoposide with or without pembrolizumab, the PD-1 inhibitor. While the addition of pembrolizumab did improve progression-free survival, it did not meet its predetermined statistical threshold for significance for overall survival. Unfortunately, KEYNOTE-604 and pembrolizumab, a negative trial. And so where it stands today is that our frontline standard of care is atezolizumab with carboplatin and etoposide, or durvalumab with platinum etoposide. For patients who do not receive immunotherapy for whatever reason in the frontline setting, nivolumab and pembrolizumab have accelerated approval in the third-line setting. Beyond chemoimmunotherapy in the second-line space, our historic standard was topotecan. This based on a trial where patients were randomized to topotecan or CAV. This included only patients with chemo-sensitive small cell lung cancer, defined as a 60-day interval between end of treatment and enrollment. There was actually no difference in survival between topotecan and CAV, but topotecan was better at symptom palliation. We see a response rate of 24% and a median survival of about 25 weeks. This, however, is a toxic treatment and not well tolerated by some patients. Fortunately, we do have a newer option, and that is lurbinectedin. Lurbinectedin is a marine-derived transcription inhibitor. The accelerated approval was based on a single-arm phase 2 study of lurbinectedin, which enrolled over 100 patients with relapsed small cell lung cancer. Patients receiving monotherapy at a dose of 3.2 milligrams per meter squared every 3 weeks. We saw an impressive response rate, 35%, with a median survival of 9 months. If we look at chemo-sensitive disease using a chemo-free interval of 90 days or greater, we see even better outcomes with a response rate of 45%, a survival of almost a year. And in the chemo-refractory setting, with a chemo-free interval of less than 90 days, where we have no good options, we saw activity with a response rate of 22% and a survival of 5 months. This clearly meeting a need. Based on these outcomes, the FDA granted accelerated approval to lurbinectedin in the second-line setting in June 2020. This is a good approval and an active agent, and if we compare lurbinectedin to historic outcomes with topotecan, we see a better response rate, better overall survival in that sensitive population, and activity in that resistant population. But to temper expectations, If we look at a more recent control arm, such as the control arm from Checkmate 331, which included topotecan or amrubicin, while the response rate was lower, the survival numbers were comparable to lurbinectedin. Is lurbinectedin clearly superior to topotecan or amrubicin? When we look at the amrubicin phase 2 study, we saw an even higher response rate in both the overall population and the resistant population, and survival numbers that across trials even seemed higher than lurbinectedin. But we know that the randomized trial of amrubicin and topotecan did not show a survival difference between the two drugs. Is lurbinectedin clearly better than amrubicin or topotecan? We don't know. Granted, amrubicin is an active agent and approved in Japan in this setting, but we'll learn a bit from the Atlantis trial. This is a randomized phase 3 trial for patients with small cell lung cancer where the randomization is to chemotherapy, either topotecan or CAV, or lurbinectedin. However, it's a combination of lurbinectedin with doxorubicin, and it is a lower dose of lurbinectedin, and so it will be challenging to interpret these results. We'll have to interpret them very carefully. I hope this is a positive trial, if only to avoid the Atlantis is sinking puns that are sure to follow a negative study. What else is on the horizon for small cell lung cancer? DLL3 is a marker that's highly expressed in small cell and large cell neuroendocrine tumors. An antibody drug conjugate called rovalpatuzumab tesirine, or ROVA-T, showed clear activity demonstrated by this waterfall plot. We spent a lot of time learning how to say rovalpatuzumab tesirine, but all for naught, because these larger trials had less favorable results and a high and unacceptable toxicity rate. Rovalpatuzumab tesirine no longer in development, but I don't think this invalidates DLL3 as a target. It's selectively expressed highly on these tumor cells, low expression on normal cells. To me, that represents a viable therapeutic target, a unique context of vulnerability. And there are drugs in development that are targeting DLL3, AMG 757, a bispecific T-cell engager antibody, or BiTE molecule, and AMG 119, adoptive CAR T-cell therapy. We look forward to seeing some results from these trials in the years to come. Another interesting modality is targeting the DNA damaging response pathway, or DDR. Olaparib, a PARP inhibitor with temozolomab, was explored by Dr. Anna Farrago at Mass General. In relapsed small cell lung cancer, we saw promising activity and median survival here of 8.5 months. What's interesting about this pathway is when we target PARP or CHEK1, we increase PD-L1 expression, and there really seems to be a synergy between PARP inhibition and PD-L1 therapy. By blocking PARP or CHEK1, we are increasing T-cell infiltration. And while these drugs can have an anti-tumor effect alone, when we take away CD8 positive T-cells, that effect goes down, really suggesting that it is an anti-tumor immune-mediated effect, even with the CHEK1 or PARP inhibitors alone. What are the next steps for small cell lung cancer? When we look at the survival curve shown here from Power 133, while it's clear to me that the addition of atezolizumab improves outcomes, while it's clear to me that it's better than what we used to do, I acknowledge that there is clearly room for improvement. How do we raise that survival curve? How do we deliver that meaningful benefit to more patients? Well, it's clear that the benefit is driven by a subset of patients. So what we need here are biomarkers. Unfortunately, that's been challenging for small cell lung cancer. These are central tumors in patients who are symptomatic with a lot of comorbidities. And so the diagnosis is often by bronchoscopy or fine needle aspirate. This course is often too rapid for repeat biopsies, so scant tissue is very common for small cell lung cancer. It's been a consistent challenge in trials to acquire tissue here. When we think of biomarkers for immunotherapy, PD-L1 is what we use for non-small cell lung cancer. What do we know about PD-L1 in small cell? Well, using the SP263 assay in Empower 133 and in Caspian, we see that in both of those trials, most samples were not evaluable for PD-L1 expression. And in samples that were evaluable, the vast majority were PD-L1 negative. We saw more expression if we included immune cell expression, but in Empower 133, PD-L1 expression, regardless of what cutoff you used, was not useful in identifying patients more likely to respond. Same results in Caspian. PD-L1 not useful in patient selection. What about tumor mutational burden? Blood TMB was evaluated in Power 133 after showing a predictive role for PFS with second-line atezolizumab in non-small cell lung cancer based on work by Dr. David Gandera. However, whether you use a cutoff of 10 or 16, and whether you're above or below that cutoff, you get benefit from atezolizumab. It's not useful in discriminating patients more or less likely to derive benefit. What's more likely to be a biomarker is looking at different subsets of small cell. Here, work done by Dr. Charlie Rudin, looking at subsets based on expression of transcriptional regulators. Importantly, these subsets can be established using immunohistochemistry, and so we may not need large samples to do this. And one can certainly envision a future where, based on these specific transcriptional subset, we will be able to choose or select specific therapies. However, it's too early to implement this. More work does need to be done. So to conclude here, small cell lung cancer remains a highly lethal disease. Most of our patients with small cell are only going to get one opportunity at therapy, and our standard of care in the frontline setting is combination chemoimmunotherapy. Adding atezolizumab to carboplatin etoposide improved survival and was approved by the FDA in March 2019. Adding durvalumab to platinum etoposide improved survival and was approved by the FDA in March 2020. Novel agents and combinations are being explored that can build upon these regimens and further improve outcomes, but really efforts to identify unique subsets and develop reliable biomarkers within small cell are critical for the further major advances that we expect for small cell lung cancer. Thanks so much for tuning in.
I would like to thank the OncoAlert Colloquium organizers for inviting me to give you highlights of radiation oncology advances in lung cancer from this year. We have several topics. A lot has happened this year that range from updates on locally advanced non-small cell lung carcinoma to advances in radiation techniques to reduce toxicity, brain metastasis management, of course, radiation and immunotherapy, and at the end, some words about a few words about predictive biomarkers. So let's start out with the 3-year update of Pacific, randomized controlled trial with and without adjuvant durvalumab, which now has an almost 3-year median follow-up. The patient group included stage 3 non-small cell lung carcinoma, mostly treated with cisplatin etoposide and carboplatin paclitaxel, not so much pemetrexed actually, with a median radiation dose of around, I think, 63 gray, if I remember correctly. And the data really shows that the benefit of durvalumab is maintained even long-term, now 3 to 4 years out, as you can see here in this graph, which was expected, and the benefit is still holding across most patient subgroups. Important to point out that the patterns of failure with and without durvalumab, we're still waiting for them. I think it'll be very much of interest to see whether durvalumab not only reduces the risk of distant failures, but also impacts local failure rates, which remain high in lung cancer. To this end, one more word about the subgroup benefits. EGFR mutant lung cancer, whether durvalumab is a benefit there remains unclear based on the data, which are really driven by small sample size. It may not be beneficial. And for low PD-L1 expression in tumor cells, so less than 1%, it's also not clear based on this analysis published earlier this year, which has led to differences in approval for durvalumab. In the United States, durvalumab is given irrespective of PD-L1 expression. Also published this year, the RTOG 0617 5-year update, which studied dose escalation from 60 to 74 gray and the addition of cetuximab. With longer follow-up, essentially the same results. 74 gray remains associated with worse outcomes and more toxicity, including esophageal toxicity, 70% grade 3 or higher. And as you can see here from the table, with 60 gray now remaining a standard of care, and 74 gray not really improving things, local failure and regional failure and combined local regional failure remains a major problem in this setting and really requires treatment intensification. And this is an important challenge. How do we do that? It remains an open question whether a moderate dose increase from 60 to 70 gray with better techniques and tighter normal tissue constraints can be achieved. The addition of an immune checkpoint inhibitor concurrently is being studied, and trials have been published already. Others are also ongoing, and we're waiting for results. Trials that add a targeted radiosensitizer to reduce local failure. For example, PARP inhibitors are being studied. And with all of these potential treatment intensifications, really the question remains how we limit or reduce pulmonary, esophageal, and cardiac toxicity. Historically, we have not quite figured out yet how to optimize esophageal and heart sparing, as illustrated here, taking constraints from RTOG or 617. So there's a lot of work to be done, an opportunity to reduce toxicity in our patients while still trying to improve local and distant outcomes. And achieving this will require more than just 3D conformal radiation therapy, namely really the use of IMRT or in fact particle therapy. So that moves us to the next topic, which is radiation toxicity. The MD Anderson, which has really been a leader in the country to investigate the potential benefits of proton radiation in lung cancer, just published an update from randomized as well as prospective data to compare traditional passively scattered proton therapy. Think of it as 3D conformal radiation therapy as we would use for protons versus the IMRT equivalent, which is IMPT or pencil beam radiation therapy, median dose 70 gray. And very clear in their data is that IMPT is associated with better lung and heart sparing without compromising tumor outcomes. Limitations apply, small patient number, potential for selection bias, since this was not a randomized comparison. And important to point out that RTOG 1308, comparing 70 gray with protons versus photons, is still ongoing, and we're staying tuned because this will answer the question of the benefit of protons in lung cancer. Another update from the ASTRA meeting from this October is a small phase 1 trial in locally advanced non-small cell lung carcinoma in small cell lung cancer that recruited patients with gross tumor within 1 centimeter of the esophagus and delivered 70 gray with IMRT with concurrent chemotherapy. And it tested a concept where IMRT was delivered in a way that was designed to spare the contralateral esophagus, with the idea being that the contralateral esophagus was contoured as an avoidance structure to guide a very steep dose fall-off from the side where the tumor received prescription dose across the cross-section of the esophagus. And the idea here was to allow mucosal regeneration during a several-week course of radiation therapy. And so in this trial, there was no case of grade 3 esophagitis, despite having the requirement for tumor within 1 centimeter of the esophagus, and despite delivering 70 gray instead of 60 gray. Grade 2 esophagitis was 25%. 2-year overall survival was as expected. And so this is an interesting concept to try to really convert the esophagus from a serial organ to a parallel organ where maintenance of organ function, at least partial organ function, can reduce the rate of severe reactions. Obviously, limitations apply here. Single center study, small number of patients, and it needs to be replicated by others. A similar idea from the University of Toronto, a randomized trial here actually with 90 patients in a palliative setting, and again using IMRT or leveraging the power of IMRT really to try to reduce esophagitis rates. And this was evident, especially for 30 gray and 10 fractions, as you can see here. And so the esophagitis reduction was achieved by limiting the maximum dose to the esophagus for the 30 gray fraction regimen. For the 30 gray regimen, that was a max dose of 24 gray. So this is also very, very intriguing and also potentially a practice changing. And then last but not least, the big reveal, if you will, at the recent ESMO meeting was the Lung-ART trial, which was more than 10 years in the making. It enrolled around 500 patients or so over a course of 11 years. Most of patients were enrolled in France. Median follow-up 5 years. As you can see here in this schematic, the trial enrolled completely resected non-small cell lung carcinoma with proven mediastinal nodal involvement. And most patients indeed received post-operative chemotherapy. Some also had preoperative chemotherapy. And then patients were randomized to observation versus mediastinal radiation, 54 gray, delivered over 6 weeks. And there was no improvement in outcomes with PORT, as you can see here. And in the analysis of first failure events, you can see that PORT was able to reduce the risk of nodal recurrence, as would be expected from historical data, but this failed to translate into improved 3-year DFS or OS. And as you can see, in the last row on the right is that the rate of death was really increased unexpectedly in the PORT arm. And this was mainly due to cardiopulmonary toxicity as a cause of death in the PORT arm. And as you can see here in this list, there was clearly a detriment to radiation. So invoking the old meta-analysis data where it was unclear whether there was a benefit, but in the PORT meta-analysis there was also old radiation techniques used, and so this mirrors it a little bit. Of course, the radiation was much more sophisticated here. 3D conformal radiation therapy in the vast majority of patients, 11 patients were treated with IMRT, very reasonable median lung V20 of 23%. The median heart dose was 13.4 gray. And so this is a very important trial. It's very hard to enroll patients to randomized trials with and without radiation therapy. So really kudos to the authors. So what do we do with these data? The toxicity that was observed is really a bit of a setback and unexpected, and it may be related to field size. If the subcoronal stations are included in all patients, it will drive up the radiation exposure of the heart, and may have contributed. And so while this trial likely will establish that PORT is not the standard of care in this patient subgroup, whether there is a potential benefit of IMRT in this setting, that still remains to be explored. So moving on to brain metastasis, published this year is the NRG randomized trial comparing whole brain radiation therapy versus hippocampal sparing IMRT with memantine. About 500 patients, more than half of them lung cancer. And clearly, hippocampal sparing was associated with better neurocognition without really any detriment in PFS or OS. So this is clearly practice-changing trial. Another very interesting trial that came out, well, a retrospective analysis really, but it's a very large number of patients in small cell lung carcinoma, multiple centers, around 700 patients, compared first-line SRS versus whole brain radiation therapy. And, similar to the non-small cell lung carcinoma space, as expected, there was a higher rate of intracranial progression after SRS, but no detriment to overall survival. We still need to see what the comparison is in terms of neurocognition and radionecrosis, but these are very intriguing data and suggest that similar to non-small cell lung carcinoma, SRS does have a role in the treatment of small cell lung carcinoma brain metastasis. And there are trials ongoing on planning to address this question in a prospective fashion. Moving on to radiation and immunotherapy, and I just want to highlight, also in the interest of time, we only have 20 or 25 minutes reserved for this. I wanted to highlight radiation and immunotherapy, where just published the Pembro-RT trial and randomized phase 2 trial from MD Anderson were pulled together to increase sample size. 150 patients with different radiation schedules and a slightly different way of scheduling it. But the addition of radiation therapy was associated with a median progression-free survival of 9 months versus 4.4 without. And the best out-of-field response, out-of-scope response, was an impressive 40% or so with radiation therapy. And so clearly this needs confirmation in an appropriately designed phase 3 trial, but it is intriguing data and improves, I think, the presence of an abscopal effect in some patients, although we urgently need biomarkers to identify that subset of patients. So last but not least, predictive biomarkers for non-small cell lung carcinoma, and I'm going to do a little loop here to reintroduce you to the concept of tumor control probability curves in radiation therapy, which is very different from drug responses, where you either get a response or you don't. Radiation doesn't work quite like that. And so, for a given tumor, given size, in a patient, it looks like this. This is a sigmoid dose response curve. On the y-axis, you have local tumor control probability versus total dose, with plus minus chemotherapy, usually with chemotherapy. And as you can see, that absolute radio resistance really doesn't exist. You can overcome resistance with appropriate dose escalation. Obviously, the normal tissues do get in the way at some point. But it also suggests that if you have lung cancer where local failure is around 50% or so, which is at the steep part of the curve in a given patient, that even a little bit of dose increase can actually have a big effect on local control. That is very important to remember. And every patient is different. Every tumor is different. And so there are different cancers. So the one in the middle here is the one that I showed you before, where 6 gray gives you around 50% local control or so. And then there are patients that have very radiosensitive disease, where you actually need less. And sensitivity could be because of genomic markers, which I will mention in a little bit, or maybe because there's a potent immune response. And then there are other cancers that are very radioresistant. It could be because of biology. It could be because of tumor bulk. If you have a 10-centimeter cancer, very, very difficult to eradicate all these tumor stem cells or collagens with radiation and chemotherapy. So in a population, in a clinical trial population, a clinic population, it looks like this. You have a wide range of different sensitivity, and the population-based curve can be very flat and may not be very helpful, if you get these data from a randomized trial to predict how your individual patient that comes through your door will respond. So if we could have biomarkers that would allow us to at least identify the radiosensitive end of the spectrum with the radioresistant end versus patients that have such resistant disease that you shouldn't even bother doing any radiation, I think that will be very helpful for clinical practice. And so published just a little bit ago and also presented at ASTRO. It's a potentially practice-changing report out of Stanford, Max Dean and colleagues, who looked at mutations in the transcription factor NF2 activating mutations, or in the regulator protein that interacts with NRF2 KEAP1. And I want to go into the detail. You can read up the paper. But it's really quite striking how aberrations of this pathway lead to resistance to radiation therapy, both in the chemoradiation setting, here shown in the upper left, as well as in the SBRT setting. And in contrast, in the surgical cohort for comparison, there was no effect. So clearly, this seems to be a predictive biomarker rather than a prognostic one. And it's also important to note not that every KEAP1 mutation is created equal. There are mutations that are have a phenotype and others that are not. So a very, very nice paper. I strongly encourage you to read it. But it also impacts, potentially every practice. I'll get back to this in a second. Another paper from Memorial that came out looked at another mutation, looking now at the radiosensitive side of the spectrum, mutations in the ATM, DNA damage response kinase. The authors looked at loss of function mutations, predicted loss of function mutations versus other variants in a large number of patients, mostly palliative radiation therapy, different histologies, but also including lung cancer. And pretty consistently, they observed that mutations in ATM were associated with improved local outcomes. So very intriguing. Needs validation, obviously, but does suggest that we can use these mutations for clinical practice. Well, not quite yet, but we do get these mutations in NGS panels at our institutions. An example here from one of my patients, it can be a little overwhelming, not only to needing to interpret these mutations, is this ATM mutation, is this KEAP1 mutation really having an impact, but then also if you have them both occurring, or does this give you a radiosensitive or radioresistant cancer? Not quite clear. And what do you do with it? Do you really do dose de-escalation, or do you really do dose intensification? No, you don't do that outside a clinical trial, but clearly we have the foundation here to be moving towards precision oncology, even in the non-metastatic setting. So then to conclude, I showed you that, I highlighted that local failure rates are still high in stage 3 lung cancer and remain a major clinical problem and require treatment intensification, with the Pacific and RTOG 0617 trials giving you a very strong foundation where we can work from. I showed you some potentially practice-changing data, especially with regard to hippocampal sparing for brain radiation therapy, the LUNG-ART trial, which removes port from standard of care considerations at this time, and then perhaps IMRT for the use of esophagus sparing both in the palliative and stage 3 setting. These studies highlight the need for continued development of highly conformal radiation techniques to minimize treatment toxicity as we try to intensify treatments. And certainly the foundation now exists for slowly but surely moving away from one-size-fits-all radiation therapy towards biomarker-guided radiation use, which will require prospective validation. So thank you very much, and thank you again to the OncoAlert organizers and collaborators for having us.
Hi, I'm Lecia Sequist from Massachusetts General Hospital Cancer Center. I'm going to speak with you today about lung cancer screening. Thank you so much for tuning in, and thank you OncoAlert for asking me to speak about this important topic. Here are my disclosures. Lung cancer is the leading cause of cancer death worldwide, and unfortunately, the majority of patients already have advanced stage disease or incurable disease at the time that their diagnosis comes to light. But it is a cancer that is ideally positioned for screening because there is a population that we can identify that is at higher risk, namely those who smoke. In the past, in the 1970s and 80s, there were many trials done trying to figure out if lung cancer screening could be effective using chest x-rays and sputum cytology. Those technologies failed to provide a benefit or overwhelmingly earlier diagnosis and improved survival. And so for many years, it was thought that lung cancer didn't have an effective screening technology. Of course, that changed in 2011 with the publication of the National Lung Screening Trial, or NLST. So this was a large trial done in the US, organized by the National Cancer Institute, over 54,000 participants. They were all smokers with a 30-pack year or more history of smoking and age 55 to 74. The screening modality was low-dose CT scan, LDCT, and the control arm here was chest x-ray, and so participants were randomized to receive one of these screening modalities at baseline and then annually for 2 more years. And the take-home points from the NLST are that even this short interval of just a few years of screening was able to achieve a 20% decrease in the risk of death from lung cancer and a 6% decrease in all-cause mortality, proving that it is an effective screening modality and that screening for lung cancer saves lives. Now, there have been a number of concerns and consequences that have come up after the NLST, but I think if we look at the paper in a journal club type of assessment, the main concerns are the poor specificity of LDCT. In other words, a lot of nodules are uncovered that turn out not to be cancers. These false positive findings, especially if you look at it at one point in time with just one CAT scan, these false positive findings can be quite high. There's also been a concern voiced about the potential complication of procedures order to follow up on lung nodules. But the majority of complications that arose in this randomized study were actually among the patients who ended up having cancer. It was a very low complication rate among benign nodules. So what came next? One big advantage or one big advancement in the field has been the derivation of the lung-RADS classification system. So this is a project that was spearheaded by the American College of Radiology and basically put in place a system of interpreting lung nodules that ended up having a better specificity than the system that was part of the NLST, what used to be called the LCAP system. So in lung-RADS, essentially they raised the size of the nodule, which would trigger a positive finding report from 4 millimeters to 6 millimeters and all the way to 20 millimeters for a lesion that was a pure ground glass opacity. In addition, lung-RADS emphasizes the need for follow-up. And so you can see on the right side of the screen that the NLST nodules that were classified as positive but were actually false positives, the number of those that can be avoided with looking at the same set of scans from the NLST with the newer, better lung-RADS system is quite impressive. The baseline scans, 52% of those that were classified as positive are classified as benign or reassuring, and after baseline, 76% of lung nodules found and called positive on NLST are now understood to be benign on lung rads. And this also emphasizes a very important point, that lung screening is a program, not a single test. The follow-up and to see what happens with an inflammatory lung nodule after a few months of follow-up is very important in avoiding unnecessary procedures and false positives. So now that lung rads is in place, what happened next? Well, CMS, the Centers for Medicare and Medicaid Services, put some guidelines forward in 2015 that basically told the US medical system how lung screening would be reimbursed, which essentially influences the way that medical systems take up the test. And some of their guidelines followed exactly the NLST data, so we're very evidence-based, like the age range and the smoking history that was required. But two things that were not necessarily part of the NLST is that CMS required that patients have a written order from a physician to be able to have an LDCT, and that also there had to be a documented shared decision-making visit. So on the face, these two things sound reasonable. You would want a doctor to order a screening test, potentially, and of course you would want the patient and the doctor to engage in a discussion, and the patient's wishes should be part of the decision making. But what's really, that's the face of it. If you think about this and you look into other health policy regulations, you'll see that other radiographic screening does not necessarily require a written order. Importantly, a mammogram does not require a physician's order. Any woman can present to a mammography department and ask for a screening for breast cancer, whether or not they have an established relationship with a physician. And that's different for lung cancer now. And then, of course, it is important to undergo shared decision in all medical care, but to actually have to document a shared decision-making visit is something that was new, that other screening tests do not have to meet, and which healthcare systems, when thinking about how to implement lung cancer screening, really struggled with, because they didn't know what exactly constituted a shared decision-making visit. How rigorous did this have to be? Did this have to be a 30-minute visit talking solely about this? Did there have to be a consent signed? So a lot of medical systems actually delayed their implementation of lung screening quite a bit out of concern of meeting this requirement for reimbursement. And these are just two examples of some of the barriers that have been placed between the patient who might have lung cancer and accessing lung cancer screening, which could lead to earlier detection and potentially save their life. Unfamiliarity with the guidelines, these shared decision-making visits, the cost concerns. Also, I think as a generalization, the medical field has some skepticism about the evidence, some misperceptions, and stigma about the patient population who needs a screening. And there also have been unclear systems, at least in some medical settings, about how to manage abnormal results and who will own that. The result is, for the first 7-8 years after the NLST came out proving that screening saves lives when it comes to lung cancer, in the US and really worldwide, a fraction, less than 10% for sure, less than 5% in many settings of eligible patients were actually accessing screening. So what's new in 2020, and what can we do to improve even further moving forward? Well, new this year are the published results of the Nelson study. The Nelson study was the second largest randomized control trial of lung cancer screening, and it was published in the New England Journal of Medicine in 2020. This is a study done in the Netherlands and Belgium. It was a much smaller study. Recall that NLST had over 54,000 participants. Here, only 13,500 participants, and they were mostly men. They started off, the study was originally conceived as being all men, there were a small group of about 2,000 women that ended up joining the study in the later years, and they're not reported as part of the overall results in the first paper in New England Journal, although spoiler alert, the screening was actually even more effective in the women than in the men. And this also is something that's been found in the NLST population. So anyway, some differences between Nelson and NLST. So Nelson looked primarily at men, and the screening was over a longer interval of time. They did a low-dose CT at baseline and then at years 1, 3, and 5.5. And the interval of the between the scans also gradually increased over time. And they also examined the nodules or categorized them as far as if they were worrisome or not in a slightly different way using volumetric measurements. And what they found is that the lung cancer specific mortality also benefited quite a bit from screening. There was a 24% reduction in the risk of death in the screen group. This study was smaller and it didn't have the power to determine if there was an overall all-cause mortality benefit. But if we take the results of Nelson and NLST and put them in context with some of the other randomized studies published, like MILD and Dante, you can see again that NLST is by far the largest study. Nelson is the second largest, and when we start getting into the other trials, they're really quite small, 4,000 and 1,000 patients. They all have a slightly different design, but some interesting findings are that even the MILD study, which again was only 4,000 patients, did show a reduction in lung cancer specific mortality. So I think it's quite clear at this point that lung cancer deaths are lower with screening. And when we look at the only study that was really powered to look at overall mortality, it was also positive. Women may do even better than men with screening. This may have to do with the biology of cancers in general, lung cancers in general in women compared to men. Of course, to benefit from screening, you want a cancer that is growing fast enough or is biologically meaningful enough that it's not an overdiagnosis. So you do want to try and find those cancers that are ultimately going to threaten patients' lives. That's where you can make the most difference. But you don't want cancers that grow so fast that between the screening intervals, the cancer can both appear and also become metastatic. And it may be that women are more likely to have the right type of biology of lung cancer to benefit from screening. At least that's the one of the prevailing ideas about this. So what's next for lung cancer screening with LDCT? Well, more randomized controlled trials are unlikely to be done. At this point, the evidence is pretty strong that it is beneficial, and so it wouldn't be ethical to randomize people to no screening. I think one thing is we need to decide as a society if screening smokers is worth the effort. There's a lot of stigma towards smokers and towards lung cancer, which many view as a disease that patients brought upon themselves. One of the benchmarks about screening tests is this number needed to screen statistic, NNS. This is how many people do you need to screen per year in order to save one life from cancer. And you can see that lung cancer screening with LDCT has a very reasonable number needed to screen of about 300. We are not undertaking this screening as robustly as we are screening for colon cancer, breast cancer, and cervical cancer, which have much higher number needed to screens in order to save one life. So a lot of this has to do with our preconceived notions and our stigmas about lung cancer. Secondly, I think we need, as a medical system internationally, to remove barriers to access, which we spoke about before, and improve systems to manage nodules. And there's been a lot of data published on this that's beyond the scope of today's talk about multidisciplinary review, setting up pulmonary nodule clinics, and really how can we best manage lung cancer screening so that nodules which are benign can be classified as such, and nodules which are cancer can be removed. In the US, there's been a move in 2020 as well to broaden the tent or open the doors wider for screening. And a lot of this is in order to improve racial equity, which is a great trend to see happening. So an organization called the USPSTF, which is the United States Preventative Services Task Force, they're the organization that vets screening and gives recommendations. They give grades of different recommendations, like an A grade or a B grade, and a lot of the US policies and reimbursements follow depending on what grade they get from the USPSTF. So the old recommendations for lung cancer screening of having to be 55 to 80 years and a 30-pack year history are now hopefully being changed. There's a draft proposal that was put up this summer, and it's open for public comment. They want to lower the minimum age for lung cancer screening from 55 down to 50 and lower the minimum pack years of smoking history from 30 to 20. And the main impetus for doing this is that Black patients who are diagnosed with lung cancer tend to have a lower age and a lower smoking history. And so the way the current guidelines are set up, we're doing a better job of screening white patients than Black. So hopefully that will soon become a full-fledged recommendation. But even so, we need to do a much better job screening the eligible patients, whatever the eligibility criteria are. For the first several years of lung cancer screening, the rates were very low, less than 5%. There was I guess a reassuring publication in 2020. It all depends on what your point of reference is, but they looked at screening in the year 2017 in 3 states, Florida, Nevada, and Georgia, and found that 16.3% of those eligible were screened. So this is certainly progress, but a long way from where we want to be, which is probably upwards of 70% of those eligible being screened. Not surprisingly, the biggest risk factor for not receiving screening that was appropriate was lack of insurance, which speaks to some broader changes that are needed in our medical system. Even if we screened 100% of the patients who were eligible for lung cancer screening, though, we would not be screening everyone who has lung cancer. And we know this because the people who walk into our oncology clinics diagnosed with lung cancer, a majority of them actually don't fit the guidelines for screening, because the screening is set up to really detect smoking-related lung cancer. And that is appropriate and a good place to start. But we also know that a lot of patients who are diagnosed with lung cancer today were either never smokers or quit more than 15 years ago, which puts them out of the eligibility of lung cancer screening. You have to have quit within 15 years by the NLST criteria. So you can see the bar graph here shows that for both men and women, over time, the percentage of patients that meet the NLST criteria for screening, these are patients with lung cancer, is falling. And from 2011 till today, my guess is that it would fall even more outside of those ranges. So we need some novel approaches to screening. And I think that's what I'm really excited about for the future. So because of time constraints, I'm not going to be able to talk about a lot of really exciting technologies, and I'm not going to touch on things like volatile organic compounds in exhaled breath or various machine learning, computer science, artificial intelligence based methods to improve lung cancer screening. But in the remaining couple of minutes, I will touch on some liquid biopsy technologies. And, liquid biopsies have become a really integral part of cancer care and diagnosis, especially in patients with advanced disease. I mean, lung cancer is a prime example of this, because when someone's diagnosed with advanced lung cancer, If it's non-small cell lung cancer, we want to know about the different mutations that are involved because it really has quite an impact on our treatment. But for early stage cancer, there's a great promise or a hope in the idea of using blood-based markers to help diagnose not only lung, but all types of cancer. And of course, the blood in a liquid biopsy has several different types of analytes that could be considered, from circulating tumor cells to circulating tumor DNA, exosomes, and proteins in the plasma as well. The hurdles for early detection are that the tumors are very small, and so anything that they're secreting is quite a tiny amount, quite a needle in a haystack type of problem. If we're looking at genetic markers like ctDNA, we don't necessarily know which genes to assay because we don't have tumor-informed approach. And all of these types of analyses require quite a bit of informatics ability, and then which population is the best population to study. So I just want to hit on a couple of papers. There've actually been a lot of really exciting liquid biopsy papers in early detection of cancer in the last couple of years, but probably one of the most notable is out of the Johns Hopkins group, Cohen et al., with their publication of CancerSeq, an assay which is now being commercially developed by Thrive. And here they looked at 16 different genes, including 61 regions of interest within those genes, and 8 protein markers. They tested over 1,000 patients, just over 1,000 patients with 8 types of cancer, including 41 patients with lung cancer, and also 812 controls. And they were looking at the difference in the ctDNA and the plasma proteins between the cancer patients and the healthy controls. And they found in general on this bar graph, in general, their AUC for their test was 91%. But when you broke it down by stage, you can see with the gray bars that the assay was better at detecting stage 3 cancers than at detecting stage 1 cancers, which are really, stage 1 is the gold standard for early detection. And it varied, of course, by tumor type as well. Their ultimate idea is to not only be able to detect if someone has cancer, but to do a tumor-specific assay or a tissue of origin assay to figure out what type of cancer someone may have. So they also have published their tissue of origin analysis, which for lung cancer, you can see was not one of the top ones, but still pretty good. 72% of lung cancer patients, they could have a readout that lung cancer was either the top 1 or 2 choice of cancer in those patients. And then this year, they published a prospective study using the CancerSeq assay. They studied 10,000 women and had them undergo a blood test with CancerSeq. And the idea was that if the blood test was positive, they would try and figure out if the patient had a cancer. So 490 women had a positive test, and they were invited to have repeat testing because they wanted to have 2 positive blood tests before they started doing x-rays, CAT scans. So 134 women had 2 positive blood tests, and they started off with a PET. 64 of these women had a concerning finding on the PET scan, and this ultimately resulted in 26 women being diagnosed with cancer by virtue of first having an abnormal blood test. They also found 17 early stage cancers in a separate pathway. These women were undergoing age-appropriate screening. So the blood test didn't pick it up, but regular screening picked up an early stage cancer in 17 patients. So for this test, they calculated that the number needed to screen to detect 1 cancer was 683. And again, just to remind you that I showed you some of these number needed to screen statistics before. So LDCT is around 300. Another paper that came out in 2020 is one that I'm very proud to be part of. This was from a Stand Up to Cancer funded study that Max Dean from Stanford University and I led. And we were looking at the ctDNA assay that Max and his partner in crime out at Stanford, Asha Lizadeh, have developed. Called CAP-seq. So this is an ultra-sensitive ctDNA assay. And we were looking at whether this ctDNA assay could help distinguish nodules that were detected into cancer or benign. And so in order to get at this, we actually studied high-risk controls. I think this is a key difference. That a lot of these liquid biopsy studies are not necessarily using high-risk controls, they're using healthy controls. Here we used smokers who met the LDCT criteria to undergo screening and had in fact been screened and had a negative screen. So they were fairly, they were, as much as we can, they were known to be negative for lung cancer, but be at high risk. And what we saw in comparing early stage lung cancer patients going for surgery with these high risk negative controls is that the CAP-seq ctDNA assay was able to detect the cancer with a fairly high rate. And you can see in the blue and red colored bar graphs, that again, just like some of the other assays, it is better able to detect a stage 3 or stage 2 cancer, but actually our stage 1Bs and even the 1As were fairly high, greater than 50% sensitivity. So this is, I think as lots of different people bring technologies to this problem, one thing we really have to figure out is clinically, how can we implement the tests? Do we want to test patients before they've gone for some sort of radiographic screen, which is kind of what the Thrive study did, was first they started with the blood test, and for those that were positive, they went to imaging. Do we want to use a blood test to try and differentiate imaging findings in patients who've undergone imaging? And the answer may be that there's multiple different tests with multiple different applications. But I think the take-home point is there's a plethora of exciting technologies being tested in this space. So I'd like to leave you with these points. The data for lung cancer screening is imperfect, but low-dose CT screening appears to save lives, especially when carried out over a longer period, a decade, like in the Nelson trial, and with standardized management systems to decrease false positives, as has been developed with lung rads. Screening is a program, it's not a single test. Doing a short-term follow-up to see the behavior of a nodule is extremely important. We need novel ideas to improve the effectiveness of low-dose CT screening and broaden the tent to let more people in. We know that most patients who are diagnosed with cancer would not qualify for screening under the current guidelines, and so we need to broaden the tent, but we also need to let more people in the door, because even the screening test we have that works very well in high-risk smokers is not being taken up. I believe that technology holds the key to opening the doors wider and getting more people through them. And there's a lot of exciting work happening in this area. So I think that there's never been a more exciting time to study lung cancer screening. Please, if you know anyone in your family, your loved ones, yourself, who is a former smoker or a current smoker and may qualify for lung screening, encourage them to take the test. You never know, it may save their life. Thank you for your attention. Have a great day.
Hi, everyone. Jill Feldman here, lung cancer patient and advocate and co-founder of the EGFR Resistors. 2020 has been a difficult and challenging year, no doubt. but it has been a hopeful year with record-breaking advancements in research and treatment for the thoracic cancer community. Today, I will talk about some of the exciting and practice-changing research and what it means to patients and our families. In October 2020, Opdivo and Yervoy became available as the first-line treatment for patients with malignant mesothelioma who don't qualify for surgery. This drug combination is only the second systemic therapy ever approved for mesothelioma by the FDA and the first new drug regimen in 16 years. It is a major step forward, and it provides hope for a disease with few treatment options. Treating people with small cell lung cancer has remained a challenge for several decades, but within the past 2 years, both Empower 133 trial and the Caspian trial have defined a new frontline standard of care. It has also been difficult to develop an effective and tolerable second-line therapy for patients with resistant and rapidly progressive disease, but the approval of lurbinectedin has helped to address this unmet need. It was the first new non-immunotherapy drug approved for small cell lung cancer since 1998. The addition of these new treatments finally provides doctors, patients, and families with some hope for long-term survival. The benefits may seem modest to you, but it is essential to understand that we patients don't measure our lives in months. We value moments and milestones. My dad died 3 weeks before I graduated 8th grade, and my mom died just a few months before my daughter was born. So living even just a few more months can be meaningful and important to patients. In non-small cell lung cancer, despite all the growth and advancements in treatment for lung cancer over the past decade, very few have been in the early stage space, particularly in lowering the high risk of reoccurrence for patients with early stage lung cancer. Imagine if those were your odds. Well, I can do more than imagine and tell you firsthand the devastation of thinking you are cured only to learn you aren't. So I understand the excitement around the ADAURA data. It is the hope that patients with lung cancer and our families desperately need. And the cartwheel in between those curves, that is the hope that doctors can finally give their patients. Hope matters. Hope is a vital emotion for patients and our families. And it has certainly been a banner year for approvals in the treatment of lung cancer. In 2020 alone, 11 new treatment approaches were approved for lung cancer by the FDA. That has never been seen in the history of oncology for any cancer. And there are many other promising research studies underway as new data for KRAS, HER2, and others are emerging. All of these approvals are helping us live longer and better lives, and long enough and well enough to reach those important milestones. But to really increase survival in lung cancer, early detection is key. With the Nelson trial data being published in the New England Journal of Medicine in February, the USPSTF issued a draft with expanded guidelines for early detection. This proposed guideline could lead to a 13% greater reduction in lung cancer deaths compared to the current guideline, and it could narrow the racial disparities associated with the screening eligibility. That would have a huge impact on reducing disparities in lung cancer. Research is everything to us patients. It's our lifeline, our future, and the future of our children. I was diagnosed with lung cancer 11 years ago, and I have lived to raise my children because I have options that my parents didn't, because of research. That matters. Research matters. And the true value of research for us patients and our families is hope. And it has certainly been a hopeful year for lung cancer. Thank you.
My name is Ravindran Kanesvaran, and I'm a medical oncologist from the National Cancer Centre, Singapore. I'm also currently the president of the International Society of Geriatric Oncology. Today, as part of the OncoAlert Colloquium, I'm very pleased to share with you some geriatric oncology updates, particularly in relation to public policy and COVID-19. These are my disclosures. So for the overview of geriatric oncology, we've actually divided it into two parts. I will discuss at the introduction to the society some geriatric oncology updates globally that has happened over this year, some public policy initiatives happening this year as well, COVID-19 and its impact on older adults with cancer, and then I'll summarize. My colleague, Dr. Nicolo Battisti, who's the president-elect of SIOG, will be discussing cancer burden in older adults, complexity of managing these patients and updates about that, updates on comprehensive geriatric assessment and ESCO 2020, and he will summarize thereafter as well. So for a start, I would like to introduce you to the International Society of Geriatric Oncology. We were founded in year 2000. We are currently the leading international organization in the field of geriatric oncology with over 1,700 members from 80 countries. And we come together once a year in an annual meeting to discuss and share the latest research and development in geriatric oncology. We also conduct advanced courses globally to educate oncologists on their role of GEO in their daily practice. Now, our global outreach extends to the courses, as I mentioned, our signature advanced course called Treviso, which is held yearly. Unfortunately, for the pandemic this year, it's been postponed to next year. We've also had initiatives in Asia, particularly in Manila, just about a year ago. And we have a close collaboration with the International Federation of Aging, and I'll talk about that shortly. But we've also worked with many organizations all over the world, leading societies like ESMO, for example. We have a working group, a SIOG ESMO working group on cancer in older adults, which is very active. And most recently, of course, we engaged with OncoAlert, and we hope to support and get the support of OncoAlert for all our activities in time to come. Now, geriatric oncology globally. The number of persons aged 65 and older in 2019 was about 702 million. This number is going to more than double or increase by 120% in a short span of 30 years. And you can see here, it doesn't matter which subcontinent you're part of, you're going to see a lot of older adults within those subcontinents. And a lot of the growth is going to be seen in low middle income countries as well. Now, how are older adults distributed, at least in terms of their proportion of patients who have cancer? So clearly from this pie chart here, you can see that more than about 60% of both males and females who have cancer are above the age of 60 years. So cancer essentially is a disease of aging. Now, this was an update that was presented as part of the ESCO Educational Symposium a couple of months back. And basically, we outlined some of the geriatric oncology initiatives globally as it is in 2020. And whilst this field took its roots in Europe and US and Canada more than 20 to 30 years ago, where now there are very mature national geriatric oncology programs and national guidelines available in Europe. In US and Canada, there are dedicated medical geriatric oncology fellowship programs. And both these regions see very active research initiatives in this space. However, geriatric oncology has now taken shape in other parts of the world as well. So in Latin America, for example, there are multidisciplinary geriatric oncology clinics in Brazil and Mexico. In Australia, there are MDT clinics as well. And in Asia, initially with the higher income countries like Korea and Japan, and most recently, even in low middle income countries like India, there are dedicated geriatric oncology services. So what are the global public policy initiatives? This is kind of a pivot that SIOG had taken over the last 2 years, especially when we found that we had this immense amount of research in geriatric oncology that we have yet to really change much practice, and we felt that public policy was probably the way to go. So we joined forces with the International Federation of Aging last year to host a landmark global dialogue on the aging population with cancer, hoping to meet the needs of older cancer patients. And this was a very meaningful event attended by many different stakeholders, and really gave us a platform to extend our role as a leading society in promoting education, research, and collaboration in geriatric oncology. Another initiative, and this took shape about 10 years ago, nearly a decade ago, was the SIOG 10 priorities. At that point in time, led by Dr. Martin Exterman. The group at that point published this in our official journal, the SIOG official journal, which is the Journal of Geriatric Oncology, focused on 3 key areas, which was education, clinical practice, and research. And in these areas, there were further points on what we decided were priorities for the society and for the field of geriatric oncology. Now, 9 years later, we have an update on that, and this has recently been accepted by Lancet Oncology and will be in press very, very soon. Will be out online very soon, actually. Now, how has COVID-19 impacted older adults with cancer? So as many of you have experienced this pandemic has been unprecedented in the way it's changed our lives. More so if you're an older adult, and even more so if you're an older adult with cancer. So firstly, I'll discuss a bit about COVID-19 and its impact on older adults with cancers, the general implications on management, some of the adaptations we've had to make in order to make sure that our older adults are managed appropriately, and implication on their treatments as well. So this is some early data that came out with regards to COVID-19 infection in older adults. So not specifically in reference to older adults with cancer, but older adults in general. And as these studies have shown, they are more frequently symptomatic. As you can see, about 12% of patients with less than 60 years, 3% of patients less than 60 years were symptomatic, compared to 4 times that amount if they're more than 60 years. And a sizable number of them do present with subtle findings. And however, the problem with that is 77% of them eventually develop typical symptoms. And I think what is probably a red flag that is missed sometimes are the non-specific symptoms. So they may not just have the stock standard cough, shortness of breath, but they may present with fall, confusion, and worsening functional impairment that makes it very hard to diagnose this infection in older adults. And by the time it's diagnosed, it might be too late. And this probably leads to why they also suffer higher degrees of complication. Apart from having multiple comorbidities that put them at risk, it's clear that all this leads to higher hospitalization. This is some data from a modeling study in the early data that came out of China. And clearly, if you're more than 80 years and above, about 18% of them required hospitalization versus just 1% of young adults between the age of 2 to 29. There's also an increased risk of mortality, and this was seen globally, not just with the Chinese data, where about 15% of those 80 years and above died from COVID-19. As you can see, Italian and US data had shown similar findings as well. So clearly, age is a predictor of adverse outcomes from COVID-19. Now, what if you have COVID and cancer? So COVID-19 and Cancer Consortium, or the CCC-19, had published this very nice data in Lancet Oncology a couple of months ago, consisting of about 1,000 patients. About 56% of the patients were 65 and above, which is quite typical of what we see in most countries as well. Majority of patients who are who get cancer are over the age of 65. And this study was pretty comprehensive, looked at solid cancers, heme malignancies, myeloid neoplasms, and it ran across 3 countries, the US, Canada, and Spain. These are some of the key findings. Firstly, when they looked at a multivariate analysis of predictors of 30-day all-cause mortality, age was a risk factor. You can see here, ECOG performance status was a risk factor, and comorbidities a major risk factor. And patients who were older with cancer had higher rates of deaths without ICU admission, specifically those 75 years and above. And this also accelerated advanced care planning and family discussions on restricting aggressive interventions in this susceptible group. So SIOG also formed a SIOG COVID-19 working group in order to come up with some recommendations that we felt were necessary to protect our older adults and provide them the best treatment possible with all the issues surrounding the pandemic. So some factors to consider when making treatment decisions for older adults were laid out, and they were mainly related to treatment goals, types of treatments that we would offer them, what we would do in terms of modifications, patient profiles, looking at their preferences, polypharmacy, some of the key domains that form our geriatric assessment, tumor factors as well, resources that were available in particular areas or countries, and competing risks. And what was the spanner in the works was COVID-19, and that really, caused a lot of problems and distress to older adults with cancers, especially in relation to the type of care that we could deliver to them. So prior to this, one of the key tenets of geriatric oncology is providing an appropriate assessment. And this is done in the form of a geriatric assessment. So older adults with cancer form a very heterogeneous group of people. So there are some in their 60s who may not be very well functionally, have a lot of comorbidities, while there could be 80, 85-year-olds who are very fit. And the best way to tease out these groups of patients appropriately is to look at key domains as listed there: comorbidities, polypharmacy, cognition, functional status, nutrition, mood, and all these key domains form part of what we know as geriatric assessment. And the numerous benefits. One is it can predict survival, it can improve quality of life, it can reduce chemotherapy toxicity, reduce unplanned hospitalizations. So many of these studies were done in the retrospective setting. However, most recently in ASCO, and this will be updated in the other presentation by Nicolo, which I hope you'll get on, it were randomized control trials that actually showed that doing a GA and intervening can actually improve the quality of life of these patients and reduce hospitalizations substantially. So during the pandemic, one of the issues that the older adults face is that there'll be fear in attending hospitals to receive care because of the fear of contracting COVID and dying from it. So the University of Rochester SOCare model was used by the group out of Rochester, including folks out of City of Hope as well, and the University of Ohio, and they assessed the role of telehealth. And they found it to be an effective modality to deliver valuable care to the most vulnerable patients. This included a pre-visit evaluation, a phone-based one, with abbreviated questions from the GA, as you can see that's listed there. So even the GA could be adapted in such a way that you can actually conduct it over the telephone while still getting important information about the key domains, as I mentioned earlier. And subsequently, there'll be a teleconsultation by a multidisciplinary team involving a nurse, an occupational therapist, geriatric oncologists, and other MDT members. So these are some practical tips on, and many of this was published over this year as guidance on how to deal with older adults with cancer. A lot of it is also derived from studies done over the past decade or so, especially in relation to data surrounding systemic therapy for older adults with cancer. We should learn how to adapt systemic therapies, maybe less frequent dosing, and also using oral agents, for example, capecitabine versus IV 5-FU. We should think about shorter courses, 3 versus 6 months of chemotherapy for stage 3 colon cancer, 6 versus 12 months of trastuzumab for early stage HER2 breast cancer, and de-escalating therapies like omitting oxaliplatin for stage 3 colorectal cancer. We should consider delaying systemic therapy, although we must also be mindful of the role or the detrimental role of delaying too long, and in some circumstances, omit systemic therapy altogether. For example, a patient who's ER positive HER2 negative early breast cancer amongst older adults, you can probably look at omitting chemotherapy. For radiotherapy, our radiation oncology colleagues have looked at shorter courses of chemoradiotherapy for rectal cancer, hypofractionation for early breast and prostate cancer. There are also considerations to delay chemotherapy in certain groups of early breast cancer patients, or 3 to 6 months for prostate cancer while on ADT. You could also omit radiotherapy altogether, especially if it's low-risk breast cancer. There was found to be no survival benefit in older patients. Now, for surgery, on the other hand, we should prioritize the most effective and minimally invasive measures so that patients do not have to be in the hospital for very long. We could cohort operations in COVID-free areas, favor endoscopic versus open approaches, and favor procedures requiring local versus general anesthetic because the healing will be faster and shorten their hospital stay as well. We could delay surgery and consider neoadjuvant treatments with either systemic therapy like endocrine therapy for breast cancer and radiotherapy for rectal cancer, or in some circumstances, omit surgery altogether with just primary endocrine or systemic therapy for ER positive HER2 negative breast cancer patients. So I would like to thank the SIOG COVID-19 working group for all their hard work in preparing these guidelines that you can access online. And finally, I would like to summarize. SIOG is leading the way in the promotion of geriatric oncology principles globally. Our public policy initiatives and new collaborations over this past year have expanded the reach of SIOG to many parts of the world. COVID-19 pandemic unfortunately has impacted older adults with cancer severely, much more than their younger counterparts. Hence, there was a need for us to come up with guidelines and to continue to do research to see how bad an impact it has had and what kind of tools we can use, for example, telemedicine and other innovative tools that have been developed to help older adults overcome some of the challenges that the pandemic has caused. With that, I would like to thank you. And again, I would like to thank Gil Morgan and his team at OncoAlert for this kind invitation to be part of the OncoAlert Colloquium. Thank you.
Hello, everybody. My name is Nicolo Battisti, and I'm a medical oncologist at the Royal Marsden NHS Foundation Trust of London in the UK. My main clinical and research interests are breast oncology and geriatric oncology. I am the president-elect of the International Society of Geriatric Oncology, SIOG. I'm very grateful for the opportunity to present some recent developments in the field of geriatric oncology that suggest that there are no more excuses for oncologists not to apply the principles of geriatrics in the care of older individuals with cancer, and that integrated oncogeriatric care should be the current standard for the management of this group of patients. These are my disclosures. I will start giving a brief introduction on the burden of cancer in older adults, which really constitutes the reason why every oncologist is a geriatric oncologist. Then I will outline a couple of key aspects of the complexity of managing cancer in this group of patients, which is really the rationale for the routine implementation of comprehensive geriatric assessments as a standard way to evaluate their unique needs, drive the necessary interventions, and inform anti-cancer treatment decisions. Finally, I will describe the finding of 3 landmark clinical trials that have been recently presented at the 2020 American Society of Clinical Oncology annual meeting and draw a few conclusions. In 2018, for the first time in human history, persons aged 65 plus have outnumbered children under 5 years of age worldwide. Between 2019 and 2050, the number of persons aged 65 plus globally is projected to more than double and reach nearly 16% in 2050. Europe and North America have the most aged populations in 2019, but there are similar epidemiological trends in high, middle, and low-income countries alike. Also, there is a sharp increase in the incidence of cancer around the age of 65, and approximately 54% of new cases and 70% of mortality from cancer occurs in patients over the age of 65 years. Therefore, the care of older individuals with cancer is an important part of the everyday practice for adult oncologists. However, there are significant gaps of knowledge on the management of cancer in older adults. We know this since 1999, when Laura Hutchins demonstrated that among the participants to 164 Southwestern Oncology Group clinical trials, only 25% were aged 65 plus, versus 63% in the general US cancer patient population. 15 years later, we had made very little progress, as our results showed that among the participants to National Cancer Institute phase 2 and 3 clinical trials, only less than 10% were aged 75 plus, compared with 28% in the general US cancer patient population. Those few older patients enrolled in clinical trials also tend to be much fitter and healthier compared with the real world. And all of this substantially limits the applicability of trial findings to our routine clinical practice. But why is the management of cancer in older adults so complex? First, older individuals are incredibly heterogeneous. We are born more or less equal, but cancer, different health behaviors, various degrees of access to healthcare, the fact that we live in different geographical areas, comorbidities, and various levels of social engagement and support may have a substantial impact on our health, and as we age, make us increasingly diverse. Fitness is a continuum, and it is very common experience for oncologists to see very fit older patients with a longer life expectancy, no impaired functional status, adequate organ function reserve, where the focus could still be quantity of life. At the other end of the spectrum, we may see frail patients with a high burden of comorbidities, polypharmacy, functional impairments, and decreased organ function that can increase the risk of toxicity on anti-cancer treatments, and where the focus should be increasingly quality of life. In this context, there is a need to identify seemingly frail older individuals who are likely to benefit from and tolerate standard treatments, as well as seemingly fit older individuals who are prone to experience undue side effects and require modified treatment plans. The complexity of managing cancer in older adults is not simply related to changes in the pharmacokinetics and pharmacodynamics of systemic anti-cancer agents, but also to a higher burden of comorbidities, such as cardiovascular disease and diabetes, a gradual decrease in the function of critical organs such as the bone marrow, the liver, the heart, the kidneys, an increased risk of complications on systemic and local regional treatments, a lack of social support, which is incredibly prevalent now in the context of the COVID-19 pandemic, concerns on the importance of quality over quantity of life as a key metric of the efficacy of anti-cancer treatments, a higher burden of psychological distress that can frequently take the form of depression or anxiety, polypharmacy that may increase the risk of drug interactions and errors and impact on compliance, a higher prevalence of nutritional problems that may take the form of obesity, malnutrition, or weight loss, a higher burden of cognitive impairment that can frequently complicate decision-making and consenting for anti-cancer treatments, increasingly impaired functional status, including activities of daily living and instrumental activities of daily living. In general, the holy grail of cancer specialists is minimizing the risk of under-treatment and over-treatment in this population, as these risks are substantial in this group of patients. Under-treatment should include not only the use of less intensive cancer treatments in fit older adults who would otherwise derive a greater net benefit from more intensive approaches, but also not providing non-oncologic interventions to address deficits in geriatric domains, regardless of the type of anti-cancer treatment chosen. Similarly, over-treatment should include not only the treatment of cancer in older patients that would not likely lead to symptomatic improvements in their remaining lifetime, but also the use of intensive anti-cancer treatments in vulnerable older individuals where there would be greater net benefit from less intensive approaches. For this reason, the use and implementation of geriatric assessments in the routine care of these patients is recommended by international guidelines such as the American Society of Clinical Oncology, the National Comprehensive Cancer Network, and the International Society of Geriatric Oncology. Comprehensive geriatric assessment is a multidisciplinary diagnostic and therapeutic process evaluating and addressing domains relevant to the well-being of older adults, such as comorbidities, function, cognition, nutritional status, mood, fatigue, polypharmacy, and geriatric syndromes. Each domain can be evaluated with tools and tests that have been validated in older patients with cancer. Several studies have suggested the CGA provides a wide range of benefits. It can predict complications of anti-cancer treatments and functional decline, estimate survival, aid treatment decisions, identify problems which might be neglected by routine assessments, and improve the mental health, the well-being, and the pain control of these patients. However, the question remains whether the CGA does impact treatment outcomes. and 3 landmark clinical trials presented this year at ASCO 2020 have documented the positive impact of CGA on other endpoints, including chemotherapy toxicity, quality of life, hospitalizations, and completion of advanced directives. And if you think the CGA is a time-consuming process and you work in a very busy practice, there are also geriatric screening tools that can be implemented in your clinics and have been validated in this population. They can predict results of CGA in a significant proportion of patients. The routine implementation of these tools is endorsed by SIOG, although we should remember that the use of these tools should not replace CGA. And if a patient screens positive here, we should proceed with a comprehensive genetic assessment and guided intervention anyway. A very interesting aspect of CGA is also its ability to predict severe toxicities in older patients receiving chemotherapy. Based on different types of single agent and combination chemotherapy regimens, the chemotherapy risk assessment scale for high age, CRUSH score, designed by Martin Exterman, integrates an evaluation of routine clinical parameters such as diastolic blood pressure and ECO performance status, lab values such as LDH, and genetic parameters such as instrumental activities of daily living, mini mental state examination, and mini nutritional assessment to determine the risk of severe hematological and non-hematological toxicity on cytotoxic. The Cancer and Aging Research Group, CARG score, designed by Artioria, combines patient age, types of cancer, treatment characteristics such as the upfront use of dose reduction and a number of chemotherapy agents, along with lab values such as creatinine clearance and genetic domains such as hearing loss, number of falls, instrumental activities of daily living, functional status, social activity measures to determine the risk of grade 3 to 5 adverse events on chemotherapy. As you can see here, the CRUSH score was also found to outperform more commonly used measures such as Karnofsky performance status in the validation analysis. As I mentioned, 2020 has been a remarkable year for the field of geriatric oncology, as 3 landmark clinical trials presented at ASCO annual meeting only a few months ago documented positive impact of oncogeriatric care also on other endpoints that are usually far more appealing for oncologists and key stakeholders. The GAP70 study was presented by Dr. Mohile from the University of Rochester, New York, in the United States. The study involved 718 patients aged 70 years and older with incurable stage 3 to 4 cancer and more than 1 impaired genetic assessment domain other than polypharmacy, not deemed suitable for best supportive care alone and due to start a new chemotherapy regimens of similar agents with a similar toxicity risk. This was a cluster randomized study conducted in 41 private oncology practices with recommendations sent to the primary oncologist based on genetic assessments versus usual care. The primary endpoint of the study was the rate of severe grade 3 to 5 toxicity, and secondary endpoints included non-hematological toxicity, survival at 6 months, and impact on treatment decisions. In this study, the intervention involved a geriatric assessment summary and recommendations for impairments being sent by the University of Rochester team to the treating oncologist. Patient characteristics were well balanced between the 2 arms with a median age of 77 years and the prevalence of gastrointestinal, genitourinary, and lung malignancies. 1/4 to 1/3 of patients had received prior chemotherapy. The study documented statistically significant improvement in the rate of severe toxicity in the experimental arm compared with the standard arm, 50 versus 71%, along with a reduction in non-hematological toxicities, 31 versus 51%. Interestingly, the lower rate of adverse outcomes is explained by higher rates of upfront dose reductions at cycle 1 in the experimental versus the standard arm, 48 versus 35%. However, this does not correlate with any statistically significant differences in survival at 6 months between the 2 study arms. The GAIN study was presented by Dr. Lee from the city of Oakwood, Duarte, California, in the United States. Here, 600 patients aged 65 years and older with solid tumors of any stage and commencing a new line of chemotherapy were randomized to usual care plus genetic assessment-driven interventions versus standard care following a baseline geriatric assessment. This study was conducted at City of Hope, a large academic center in Southern California. The primary endpoint was the rate of grade 3 to 5 chemotherapy toxicity, and secondary endpoints included also advanced directed completions, unplanned hospitalizations, emergency room visits, and average length of inpatient stay. In this study, the intervention in the experimental arm involved a baseline geriatric assessment that was then reviewed by a multidisciplinary study team that issued specific recommendations on interventions and refers based on the geriatric assessment's results. The plan was reviewed by the treating oncologist and by the patient, and chemotherapy was given at discretion of the treating oncologist. And patient also underwent a geriatric assessment at the end of study. In the standard arm, patient underwent a geriatric assessment at baseline and end of study, but these results were reviewed only by the treating oncologists. In this trial, patients had a median age of 71 years and mostly were affected by gastrointestinal, breast, lung, and genitourinary malignancies. Their characteristics were well balanced between the two trial arms. In this population, the study documented statistically significant reduction in the rate of grade 3 to 5 chemotherapy-related toxicities, 50 versus 60%, with an absolute risk reduction of 9.9%, along with a statistically significant increase in the completion of advanced directives, 24 versus 10%, and no differences in emergency room visits, hospitalizations, and average length of stay. The INTEGRATE study was presented by Dr. So from the Monash University of Melbourne, Australia. The study enrolled 154 cancer patients aged over 70 years with solid tumors or diffuse large B-cell lymphoma due to receive chemotherapy, targeted therapy, or immunotherapy. They were randomized to integrated oncogeriatric care versus usual care. The trial took place in 3 general hospitals in Melbourne, Australia. The primary endpoint was a composite measure of health-related quality of life called Elderly Functions Index, ELFI, score, derived from the European Organization for Research and Treatment of Cancer, C30, quality of life scale. Secondary endpoints included healthcare utilizations, treatment delivery, function, hospitalization, mood, nutrition, health utility, and survival. Intervention in the experimental arm involved the geriatric-led baseline comprehensive geriatric assessment and guided interventions, including supportive care information, encouragement of physical activity and optimal nutrition, advanced care planning and vaccination status, but also investigation and management of comorbidities, medication and symptom management, and referrals to allied healthcare professionals, rehabilitation, geriatric care, and palliative care. Patient had a median age of 74 to 75 years with a prevalence of lung and gastrointestinal malignancies. Patient characteristics were again well balanced between the two arms. The study showed consistently better quality of life measures in the experimental arm compared with the standard arm over a period of 24 weeks. Also, the study documented a 39% reduction in emergency hospitalization, a 41% reduction in unplanned hospitalizations, a 24% reduction in the risk of unplanned hospital overnight stay, along with lower early treatment discontinuations, 32 versus 53%, and no differences in treatment reductions, escalations, and delays. In conclusions, these studies represent major advancements in the understanding of the impact of integrated oncogeriatric care on outcomes for older patients with cancer, and compelling evidence supporting its implementation to reduce the risk of adverse outcomes and maximize the health and the well-being of this group of patients. This is important not only to improve patient care, but also to enhance discussion with all the adults and their caregivers around age-related concerns, as beautifully demonstrated by this cluster randomized analysis of genetic assessment-guided recommendations in 541 patients and 414 caregivers, published by Dr. Mohile early this year, showing improved patient and caregiver satisfaction with communication and overall care, and it really expands incredibly the scope of oncogeriatric care in this population. These studies are also a beautiful example of clinical trials that are meaningful for older patients, and a reminder that there are ways to overcome the barriers limiting the applicability of study findings in this population and to generate more evidence in geriatric oncology. By enrolling more vulnerable and frail older individuals, by expanding eligibility criteria, allocating treatments based on fitness, and increasing the retention of enrolled patients. By selecting endpoints that are relevant to older individuals, such as quality of life, physical function, and tolerability. By including geriatric assessment tools in order to better predict toxicity and allocate patients to various treatments, and monitoring them longitudinally. And by using novel trial design strategies such as pragmatic studies and prospective cohorts. These trials also set out compelling models of care in geriatric oncology, such as the consultative models outlined by the GAP70 study, where the treating oncologist refers patients to a geriatrician or a multidisciplinary team for a comprehensive geriatric assessment and guided recommendations, and is subsequently managed by the same oncologist. Or the shared care model outlined by the INTEGRATE study, where the treating oncologist refers patients to a geriatrician, a geriatric oncologist, or a multidisciplinary team for a comprehensive geriatric assessment, and the care plan is reviewed by an interdisciplinary meeting. And the geriatric oncology team collaborates with the treating oncologist and provides ongoing care across the entire disease trajectory. Or a comprehensive care model outlined in the GAIN study, where the geriatric oncologist is the treating oncologist who also performs the geriatric assessments and sets out the required recommendations. Each model may suit different institutions, depending on the presence or lack of geriatric assessment or geriatric oncology expertise, the caseload, and various logistics. However, the algorithm should remain the same and involve geriatric screening, and for those patients found to have vulnerabilities, and oncology and the geriatric workup to be run in parallel and aiming to produce an integrated treatment plan. Whereas patients with no vulnerabilities should be managed similar to their younger counterparts. Similarly to what happened during the last 2 decades, when we have increasingly moved to consider biomarkers to drive anti-cancer treatment decisions, along with more classical aspects such as histology, grade, and stage, I believe we should do the same when considering our patients and overcome the limitation of considering only chronological age and performance status, and look at the routine implementation of comprehensive geriatric assessments to motivate treatment decisions in the context of our patients' life expectancy, organ function, comorbidities, functional status, social support, quality of life considerations, and obviously their preferences. And perhaps also investigate the potential interplay between aging biomarkers and tumor-specific biomarkers on the impact on outcomes of anti-cancer treatments. This is, to me, also precision medicine. On a final note, let me mention a few useful resources if you are interested to find more about the field of geriatric oncology. The International Society of Geriatric Oncology SIOG website, along with the relevant Twitter handles. The Cancer and Aging Research Group, CARG website, and its Twitter handle. You can find here also all the geriatric assessment tools that I mentioned. The Moffitt Cancer Center Senior Adult Oncology Program website, which is a pioneering center for the field of geriatric oncology, and where, again, you can find the geriatric assessment tools that I mentioned during this presentation. The website of the Journal of Geriatric Oncology, which is the official journal of SIOG, and the showcase of all the key research in the field. And finally, the hashtags GeriOnc, GeriHim, GeriSurgeOnc, and GeriRadOnc that you can use to interact and network with very active Twitter geriatric oncology community. Thank you very much for your attention, and goodbye for now.
Thank you all for joining us today. Don't forget to join us for day 3 of the Best of 2020 in breast cancer, liquid biopsies, molecular therapies, and immunotherapies with great presenters like Dr. Hope Rugo, Dr. John Hannon, Dr. Erica Hamilton, Dr. Sarah Tolaney, Dr. Matteo Lambertini, Dr. Christian Rolfo, Dr. Igor Martini, Dr. Vivek Subaya, and Ms. Julia Maus Okmai Makarmo. Remember, regardless of geography, we're all OncoAlert.